I think they will come, but we need to start.
Right, okay. So today I'm going to be talking about medical ethics. Any idea about this topic? Have you ever read about this topic before? Yes? No, okay. Some people are saying yes, some are saying no. Yes and Hindi. Okay. So it's good if you have some background knowledge, because it's not very clear. No, I'm not saying clear cut, but it's not something very clear cut it's not something very clear cut in the books. Okay, there are different components of that, and we'll be talking about the different components to that, and we'll be talking about that. It's not going further. How do you do that? Oh, this one. Oh,
Just
this one? I did it.
down.
Down, yeah. Okay. You want to come in? What you want? So I'm just going to tell you what we'll be doing in this presentation, what we're talking about. So obviously the definition of ethics, what does ethics mean? What are the principles of ethics, and how do we apply those principles to solve any dilemmas, to solve any conflict, to solve any issues. Consent and confidentiality, these are two important. Can you not see? If you cannot see, you can come at the front, please.
The problem more with hearing.
With hearing?
Because we have different tones of voice.
I need a mic here then. Can anyone listen to me? Or should I speak a bit louder? It's okay. You want to come here? Are you sure? Why don't you come on this side, please? Please come forward. And this seat is empty as well. Do you want to come at the front? You okay? Right. Consent and confidentiality are the two important components. We'll be talking about that, and at the end we'll do some case-based discussions. And I really want you to participate in the case-based discussions. Some cases we will discuss.
So continue.
Okay.
Okay. Okay, just black.
Yeah, I did it. Okay.
And if you want to have a pointer?
Yes. I can use this one.
And you can use this. You can.
Okay.
If you want
to. Right. So first of all, the definition of ethics. What is ethics? Now, Ray Noble is a very known scholar, and he has worked in that field for a very long time. He's running quite high. He's running a lot of courses in London on medical ethics. And if you search on the internet, there is a very nice booklet that he has published from his course about medical ethics. And I would really suggest that you look at the internet and you read that booklet. There is a lot about medical ethics in that. So he defined the ethics in his booklet that it is actually understanding of the nature of conflicts arising from moral imperatives and how best we deal with it. So ethics are very different from the laws, from the regulations, from the guidelines, because they are very set, and once they are decided, you follow them. Ethics is something that we call moral grounds, okay? And not in every case you will apply the same principles. That's how different ethics is from law, from regulations, from the rules, okay? And it's not about doing something right or doing something wrong, okay? There's nothing right or wrong. If you make a decision in something, it's not about that if you've taken an option A rather than B, it means that the A was right and the B was wrong. No, because at that given time and in that circumstances, maybe the option A was much better than the B. It's all about the choices, okay? If you have choices, then the issue of ethics will come. You apply your ethics. If you don't have the choices, then you will not have ethics. Okay, I'll give you the examples with that. So it's about what is morally right and what is morally wrong, which means that as a doctor, you act in the best interest of the patient. That is your moral duty as a doctor. So you are a moral agent, okay? Now, if you talk about the patient, then patients are also moral agent, because once you have given them all the information about any treatment or any operations, it is their choice to decide what they want to do. So a duty comes onto the patient as well. Okay, so it's not just the ethics does not just apply to the doctor, it also applies to the patient as well. Okay, because once you have given them information, your job is finished. Then the duty lies to them what they want to do. But your duty as a doctor is that that's what you need to give to the patient to make sure that your patient make an informed decision or an informed choice. Okay. So where does the concept of ethics come from? So why we think that we need to apply ethics in our daily life? It's because that when you live in a society, different people, they have different moral values, right? Whether it's coming from the religion, whether it's coming from their socioeconomic background, whether it's coming from their culture. So therefore, it is very, very important for you to take everything into account. So we are not just talking about the clinical benefits. We are not talking about what is clinically good or bad. Apart from that, there are other things that comes into account, and that is the values, that is the norms, that is the culture. You also need to take into account and respect their dignity and respect them. Because when the decision is taken by the patient, you are a doctor, you might just take a decision on the evidence-based medicine, but your patient is not a doctor. Okay, for her the important thing is her religion. For her the important thing is her family values, the socioeconomic culture. Okay, so she will keep everything in mind before she takes a decision. And what your duty is to respect all those, and that's what it is called ethics. But not just the clinical stuff. You bring every other thing into account before you make a decision. So ethics, medical ethics will provide a framework to you, making a decision about the action people are taking. So I would say it's a systematic way of coming to the decision. Okay, ethics is a systematic way. You apply different principles, and I will talk about those principles, that how you come to a particular decision. When you see a patient, when you make your consultation, how you apply those principles of ethics to come to a final decision. Okay, so it is not the set of rules. Okay, it is not law. It is not and it is not any particular formula. So therefore, you cannot apply one principle to everybody, to every case. And that's why it is a bit more confusing, and that's why it is a bit more challenging and complicated than a normal NICE guidelines or normal RCOG guidelines. But if you look at the law books, because it's not set, it will differ from one case to another case because the people values will differ. The people socioeconomic culture and the background and the family background, it will differ. Therefore, the rule of that one principle applied to everybody will not work in ethics. You need to go case by case. Okay? So we'll come to that. Okay. So what are the standards of ethics? And this is a very important slide, and you might have questions onto that. So there are two ways or two approaches that you can apply onto when you facing a conflict, when you're facing a dilemma or a challenge. There are two ways you can deal with it when we are talking about ethics. The first particular way is called a utilitarian approach, or it is a goal-based approach. Now, what is this approach? It seems very attractive to most people, and most people want to follow that approach. And the reason is that it provides an empirical solution to the ethical problems. For example, if you see a patient and there are two choices for a treatment, option A and option B. Okay. So, with this kind of approach, you say to the patient, okay, this is the benefit of option A, this is the benefit of option B, this is the harms about option A, and these are the harms about option B. So you weigh the harms and the benefits of both options, and then you see what is the outcome. So if the outcome, i.e. the benefit, is more towards option A, you say to the patient, we'll go for the choice A. Okay, so basically outcome determines the action, okay, which means whatever result will come, right, for example, this is option A and this is B, okay, so you do benefits, you look at the benefits and then harms, and here same benefits and harm. So let's see, there are more benefits with option B and less benefits and more harm with this one. So you go with the option B because there are more benefits. So with this approach, the decision based on the outcome. So the outcome was that there was more benefit with the option B, so therefore you went to option B. So that's how you do it. For example, I give you a policy where the premature, in your hospital, the premature babies, they are kept in intensive care unit. Okay, so until what age the babies should be resuscitated or kept in an intensive care unit? So you look at the evidence that what is the morbidity associated with different gestations, and then you say, okay, babies up to 24 weeks should be resuscitated and they can be admitted in the intensive care unit. And how did you decide that? You look at and then you also looked at the babies at 26 weeks, and then you looked what is the morbidity associated if you resuscitate and if you provide them care. And then you come to the conclusion that actually the babies at certain age should be resuscitated and they should be admitted because this is the evidence available. So you went with that option. Okay, so whatever the outcome was, you followed that. Okay, but again, if I challenge you, if a patient comes to you and say, I know my baby is 26 weeks and you know that the guideline or the evidence is that babies at 24 weeks can be resuscitated and should be admitted. But that baby at 26 weeks has been coming from a mother who is severely preeclamptic. The baby is severely IUGR with no fluids around the baby. There is a very serious morbidity if that baby is resuscitated or if that baby survives. So would you not discuss that with the patient? Yes, you would. You would not automatically admit the baby or resuscitate the baby. You would definitely discuss that option with the mother. That yes, we can resuscitate the baby, but the chances are that your baby will be severely handicapped. So the one option is that we just don't resuscitate. This is one option. So that baby condition is very different from a normal 26-weeker baby. So you see, your ethical and your moral duties, it varies from one case to another case. You will certainly give her option of not resuscitating the baby or terminating the pregnancy if it's severely compromised. So this is your moral duty as a doctor. You're not just following the guidelines that this is a cutoff and the babies should be resuscitated and they should be given care and everything, because that baby is very different from a normal 26-week. Okay? Right. Okay, the second approach is called deontological approach, and it's the duty-based approach. This is actually based on what doctor duty is towards his patient. For example, when I discuss option A and B, okay, you weigh the harms and benefits, okay. You selected option B because it was there were more benefits in it. But that patient who saw the doctor before you has promised that she will be given option A, or in different times, in different circumstances, you discussed with the patient before and option A was more suitable. So there are two problems here. Yes, you have weighed option B, but you have promised the patient that you will give option A at some point. So you're breaking the promise. You know, your duty as a doctor is that you have made a promise to the patient at some point that you will be giving an option A, but you weighed risks and benefits, and the conclusion was that option B is more suitable. So there is an issue that whether you should go with option B because there's more benefits, or there is a choice that you should actually go with A because you've already promised with the patient and you're going to break the promise. And then it's the loss of trust between the doctor and the patient. Okay. If you're not able to explain why you did that, then you're actually losing the trust of your patient. And then you weigh that giving this option and breaking the trust of the patient, or if you're not able to explain properly why you're doing this, which one is more harmful to the patient? Okay, so it's a different kind of approach. I will give you certain examples later on to understand those two approaches. Okay, so
I think one easy example is termination of pregnancy. You can have for example, a young a teenager is coming to terminate the pregnancy, and we applied the rule-based ethics from our view. We will terminate the pregnancy. But sometimes we have the duty-based ethics that, in my conscious sense, is not approving the decision. So, and duty-based ethics may be changed from one doctor to another.
Doctor, I think that you can apply the example. So what Dr. Ahmed is trying to say is, for example, a patient comes to you and she wants a termination of the pregnancy, okay? But for whatever reasons, that's a separate subject, okay? So she has a valid reason to terminate her pregnancy. Being a doctor, or being a doctor that has this moral value, or from the religion point of view or whatever, that you don't do terminations. Okay, even though you know that if she goes for a termination, this will be good for her mental health or whatever. Okay, she has a valid reason. So what is your moral duty now? What is your moral duty? Yes, I mean you cannot force yourself to sign the termination form, but your moral duty is that you refer her to another doctor. You make an arrangement to another doctor. Your moral duty is not to convince her she should not terminate her pregnancy because you think that's not the right thing to do. Okay, so that's
in this situation you will make an appointment for another doctor.
Yes.
So my moral.
So
because your moral value differs from what patient need is.
And we don't respect your patients.
No, you are respecting patient.
But you are respecting your moral.
So ethics, what I said in the start, ethics not only just apply to the patient, they also apply to you. Then ethics means you need to safeguard what your thinking what your values, what you know, but your duty is that should not affect patient choice. Yes? That comes as your duty. This is your obligation. But
in many situations, there is a conflict between goal-based ethics and
duty-based. Yes, there's no clear-cut line or distinction.
And we will try to do balance between them.
What is your duty and what is good for the patient?
Yes, to reach. But in many things, it's clear. There is agreement between both of them. But
yes.
In some conditions like abortion, like resuscitation in a premature age, decisions like resuscitation in I think also in
end of life resuscitation.
A patient wants to
when you should resuscitation.
So we have some conflict in many areas.
So as I said in the start, it's a very systematic way of reaching to a decision. Okay, and how do you reach to a decision? You talk to the patient, you look at what she wants, then you look at what your duty as a doctor is, what is your moral value is, and you collectively reach to a decision. Okay, so that's a very systematic way of coming to a decision between doctor and patient. Okay, I really want you to clear your concept, because if you clear your concept, you'll be able to attend the questions. Okay. Okay. Any questions up to this point? No? Yes. What is best? So, which means the same the example we said, the termination of the pregnancy. So the outcome was that you cannot offer her termination. Yes. Because that's not your moral values are. So the outcome was that you cannot offer her termination, but you will refer her to another doctor. So the best was that she should have her pregnancy terminated, yes? But that's what you are not offering her. So the outcome was not what is best for the patient. This was the outcome that you cannot offer her the termination. Okay, so the outcome may not be dependent on what's best for the patient, because that's not what your moral value is. But then comes what is your duty. And your duty is you make sure you refer her to another doctor. Okay, because if you this was based on the outcome, right?
This is in Arabic means al-ghaya tubarrir al-wasila. The end can justify the means.
Yeah, this is a very famous proverb. So, end justifies the means.
Yes. Am I right? This is for the first one.
Yes, you're right. Yes, you're right. Okay. Any questions? Do you understand these two approaches? Yes. Because what's best for the patient in that example was the termination, but we are not offering. We cannot offer her. But then you question your duty. Then what is my duty? Okay, what is the patient's right towards me? It doesn't finish at that step. I need to work forward. I need to do something different.
In some situations, we go with goal-based. In some situations,
you judge
with duty-based.
Yes.
There is no much fear.
No, it's according to the situation. Ethics differ from one case to another case.
According to you, sometimes you may
situations.
Yes, you may prefer to do your duty-based than
goal-based thing. I will give you examples, very interesting examples as we go along, and then you'll see how two approaches apply. Okay, so the objective of ethics is how to maintain respect for and you protect of the individual or a population in a situation where health and illnesses are concerned. So you need to make sure you are respecting the dignity, you need to make sure respecting the values of the patient, you need to obviously make sure that you respect your values and you perform your duty as a doctor, and that is very, very important when we are talking about ethics. Okay, this is the main objective. Okay. If you just read this, the things that I've highlighted in yellow, it will just explain to you that as a doctor, as a clinician, what is your duty. Okay. And sometimes it can be challenging for you. Okay, so same example will come into that. I'll give you examples as we go along. Okay, so we discussed two approaches of applying the ethical principles, or discussing how do you apply them into a conflict. And then there are different principles of ethics. So there are two approaches, and there are 4 or 5 principles of ethics that you need to apply to each case when you faces a conflict, when you faces a dilemma, when you faces a difficult situation. So those 4 principles are called Belmont principles, and they are very, very important, and they might come in the exam. So you need to know each one of them as to what they means. So first is the autonomy. What does autonomy mean? So autonomy means every single patient, they have a right, okay, to make their own decision. Every single human being is born free. That is the bottom line is. Okay, and they have a right to choose what they think is right for them, and you need to respect for that. Okay, so this is autonomy. The second is beneficence. Beneficence means acting in the best interest of the patient. So what is actually good for the patient? You as a doctor, you weigh the bad and the good stuff, and then whatever you do, your main aim should be that this should be in the best interest of the patient, whatever decision you take, right? Third is the non-maleficence. Non-maleficence means that first, do no harm. If you're not doing anything good to the patient, you should not do any harm, at least. Okay? Okay. And after that is the justice, which is very, very simple, and that is that all patients should be treated equally, fairly, and there should be no discrimination between the patient, whether it's race or gender or ethnic group or whatever. Okay? Sometimes non-maleficence can override the beneficence. Okay? For example, you have a treatment, you have option, and you're weighing the good and the bad, and you said that if I do this, this will help the patient, but at the same time there is a harm associated with the baby, a grave harm associated with the baby. Or take it another way. You see a pregnant lady, there is something you want to do and that's very good for the baby, but that's not good for the mother. So if you're talking about beneficence, then yes, the baby will have more benefits, but then at the same time you're doing non-maleficence, which means you are not following the rules of non-maleficence, which is to not do any harm. Okay. So for example, I tell you, and it has happened to me in one of my clinic. So there was a patient, and I was a very junior doctor at that time, and I learned my lesson. I was working in the fertility clinic, and there is there is a patient who came to me, and she wanted to get pregnant. Okay, so the usual sort of history that I took from her, she mentioned me very briefly that she had some sort of heart murmurs when she was very young, and that was never being followed later on, and she was absolutely fine. So I actually, I said, okay, we'll do this and this and this, and you'll have your investigation for the fertility, and I know you want to have a baby, and she was very much into that. So I referred her for the further treatment. Later on, she was seen by somebody else and then was found out that she actually had a very serious heart problem that was not picked up. Okay, so on one hand, I was trying to help her. I wanted her to have the baby, but just imagine if she would have gone through all the fertility treatment, she became pregnant, and that pregnancy might not be compatible with a heart condition. Okay, so sometimes the non-maleficence, which means not to do any harm, it overrule the beneficence. So first do no harm, then you think about the benefit. Okay, there's no point thinking about the benefit when you are giving her harm first.
Even if she has a consent, she won't take
No, you can't. You can't. Because then comes a duty to you. Do not do harm. It's not about the consent. Okay? If she has come to you for the fertility treatment, obviously she is consented. But at that time, she wouldn't know her heart condition. It wasn't discussed with her.
If I discuss with her and she wants to have a baby,
You cannot, because the first duty is
not to harm.
not to harm. So that's what I'm saying. You need to apply those principles. When are you facing the dilemmas, when you're facing a conflict, when you're facing challenging situations, you need to apply the ethical practice. Apart from the clinical care, you need to apply these principles as well. Before actually you apply the treatment, before you give her the treatment. Okay? Right. Any questions? So just remember these principles. They are very, very important, and as we go on, we will be talking about those principles, how we apply in different cases. How do you address the ethical issues? So when you come to an ethical issues, how do you address them? So first of all, you need to be aware of all the medical factors involved. You need to be aware of your own personal standpoints, biases, which means if you believe in something, that should not affect you giving the treatment to the patient. Okay? That is your belief. So you might be biased. If you think you are becoming biased in making a decision, you need to refer it to another doctor. Okay? You need to be aware of the legal framework of the country. So there are laws as well in the country, and when you are making a decision, you need to be aware of those laws as well. Okay, awareness of social, religious and multicultural issues. Obviously these are important because it varies from one person to another person. Willingness to involve a wide range of people in decision, and that's a very important point, and please, please, please apply those in your practical life as well. Get help, okay? Even if you become the most senior person, always discuss with your colleagues if you're not sure about anything. Okay, I was working as a senior registrar as another consultant on labour ward, but I used to take CTGs to the midwives to discuss. If I'm not sure about a CTG or a case, I used to discuss it with the coordinator. I used to ask her, what is your comment on that? What do you think of this? So there is no harm discussing and involving your colleagues in a matter if you're not sure about something. Okay, now this is very important slide. Your duty as a doctor. What is your duty? And the GMC has done a guidance, and you need to memorize that. Okay, it can come in the exams like that. So what is your duty as a doctor? And these duties as a doctor are very important when you're dealing with ethical issues. Okay. So first of all, is your first priority is the patient care. That is your should be first priority. Protect and promote the health of the patient and the public.
I think it's not different than our duties here.
Yeah. I think everywhere in the world, I don't think so just GMC has to lay that guideline. I think your duty as a doctor, if you go in any part of the world, it's the same. But GMC has shown it as a guidance because then if the problems or dilemmas arise, then no one can say actually, where it is written and where are the guidelines and what should I follow. Right? Okay. Be honest, work in partnership with patient, respect the dignity of the patient. So these are kind of normal stuff. Right. How do you practically approach? So you need to identify the problem. You need to identify the dilemma. What is the conflict? You need to understand what are the choices available. Okay. Then you need to consider what are the benefits and the harm. And you need to think which approach I will apply to the dilemmas. Okay. What is my duty as a doctor in that issue? And who does I owe my duty to? Who do I owe my duty to? To the patient, to myself, or to the society? And then you apply those ethical principles that we talked about. So these are some steps how you do that. Okay. So for example, this we have discussed before. A doctor is requested to perform termination of pregnancy. Now, a doctor cannot be forced to act against his or own, her own religious beliefs. Okay, I don't do terminations when I was working in UK, so they can't force me to sign the forms for the terminations, right? But what they do is that I can ask them that one of my other colleagues, she is okay with that, so you can ask her to sign it. So they don't actually come to me automatically. Those cases don't come to me automatically because after some time the nurses and the midwives, they know I don't do terminations. I don't sign the consent forms, and therefore when I'm doing an emergency list where there are terminations, then I don't even have to do those terminations. So I call when I was a junior, I used to call my registrar to do those procedures. And when I'm a registrar, I tell my consultant that I will do ERCPs, okay, and at the end of the list there are 2 terminations and I don't do terminations, so he comes and he does it. So it doesn't mean that if you don't do it, somebody needs to force you to do it. But again, if this is my personal belief, that should not stop me to giving the care to the patient, right? And I know that the complications can arise if she continues her pregnancy. So nothing should stop me to refer her to another doctor to make sure that her issue is resolved, her care is given. That is my duty as a doctor. What does GMC say? What does GMC say on a personal beliefs? If carrying out a particular procedure or giving advice about it conflict with your religious or moral beliefs, then this conflict might affect the treatment or advice you provide. You must explain this to the patient and tell them that they have the right to see another doctor. This is what GMC say. And you must be satisfied that the patient has sufficient information to enable them to exercise that right. If it is not practical for a patient to arrange to see another doctor, you must make sure that you arrange a qualified colleague to see him.
Without going into the details of why, because not to go into the religion point of view or whatever, what I
yeah, you don't need to say, you don't need to justify.
I am not satisfied to do this
termination. It's not just termination, it's anything. Okay, for example,
as long as it is not emergency and not affecting the
yes, that is something different.
Patient.
Okay, if it's not a religious belief, a person come to you requesting a cesarean section in the clinic. Okay, now this is not my religious belief that she should not have cesarean section, but I think as a clinician that the cesarean section. Sorry, duty-based ethics. So this is my as a clinician, I think that she should not have cesarean section because she does not need one and there is no medical indication for that. So that is my duty-based ethics, okay? Even though she thinks that this is good for her because she
will be happy to deliver with cesarean.
She will be happy because, why she will be happy? Because, because she is, well, she can have epidural, it's not a problem in UK, but she's happy because this is her last, she's not going to have any other children after that. She's not worried about her next pregnancies, and because this is going to be planned and she's going off on holidays in 2 months' time or in 1 month's time, so this exactly fits in her schedule and she wants to have a cesarean section. Okay? Everything is going in the benefit for the patient, what she wants, but this is my duty. This is, as a clinician, my moral duty. No, this is not right. So what will I do? What will I say to her? Yeah, I will try and give her or advice, yes, or how do you give her advice? Information, okay? You give her information, the benefits, the harms, and give her the choice, and if she still doesn't she's not convinced, you refer her to another clinician. Say, okay, you see my another colleague, and I'll do that. Now, we decided when I was working in Oxford, we work as a team, and there was a senior consultant, and then there were 4 or 5 of us. And so we made a team that none of us will agree to the cesarean section for if there is no medical indication. But we used to refer patients to each other. And well, the thing is, we say to the person, we actually say to the person that we can either let you see another doctor from our team, okay, or you can see any other team, but the policy in the hospital is the same. And why the policy is same? Because there is no medical indication to do unnecessary cesarean section.
But especially for cesarean section now, I think we can...
it's changing, yes. It's now the maternal choice, and it's a lot of other things are coming, but I'm just giving you an example, okay? Our aim should not just be reducing the cesarean section rate. Our aim should also be to provide safe vaginal delivery. Okay, you cannot just say to the patient, okay, you should not have cesarean section and you should have vaginal delivery, and then she ended in ICU after 6 liters or 5 liters of blood loss, and with a absolutely teared vagina and stuff like that. So your aim should also be to provide safe vaginal delivery. Okay. Right. Should we move on? Yes, we are clear? Okay. Right. So we were talking about the termination of pregnancy, so I just thought we'll go very quickly to Abortion Act 1967. Okay. This act covers England, Scotland and Wales, but it doesn't cover Northern Ireland. And this is actually the act from the Parliament of United Kingdom, and what they did was they legalized the abortion in England, okay, by the registered practitioners. And what they said is that it should be free on NHS. The abortions and the termination service should also be free on NHS like any other treatment that's free on the National Health System. So this was the act that came in 1967. And what this act done was this said up to 24 weeks it is legal, but this was then changed. A little amendment was done in 1990, and when they said that abortion can also be legal after 24 weeks in special circumstances. So if you have a question that abortions are legal at 24 weeks and they are illegal after 24 weeks, then it's not true. They can be legal after 24 weeks in special circumstances. And what are those circumstances? If it's necessary to save the mother's life, any gestation you can terminate. To prevent, if there is any indication that there is a grave permanent injury to the physical or mental health of the pregnant woman, for example, a cardiac condition of the mother. If there is a substantial risk that the child will be born with serious physical and mental disability, severely IUGR babies, right? Any congenital condition of the baby. You can terminate the pregnancy at any time. Okay. What are the legal requirements when you're going to terminate the pregnancy? So it must be carried out in a hospital or specialized licensed clinic. There are termination clinics. They are not in the hospitals. They are set up separately. And some termination services can be done in the hospital. But it has to be a proper place. You cannot do it at home. 2 doctors must agree an abortion would cause less damage to a woman. So there are different clauses. Do you know the clauses for terminations? A, B, C, D, E, E. Okay, I didn't write it there, but you must read, if you write down, you must read the different clauses of termination of pregnancy, because termination of pregnancy is a separate subject. I didn't include too much detail. I just want to cover the legal aspect of that in this lecture. So there are different clauses of the termination. There are different reasons. If the patient fits in any one of those clauses, then she can have termination. And as a doctor, you need to look at those clauses, and then you need to say, then she can have termination. So 2 doctors must agree and sign the form. before the patient is given a termination service. What are the forms that are to be filled? So HAS is the form that is signed before by the two registered medical doctors. Then there is a HSA2 form, is completed after abortion and which is usually kept for 3 years in the hospital. And then there is HSA4. This is the form that's sent to the chief medical officer within 14 days. So it's like a national entry register. So all the termination that's happening in the UK, they must be registered with the chief medical officer. There is a national register. These are the name of the forms. Okay. Okay, sex selection is not one of the lawful grounds. When I was talking about different clauses or different reasons for termination, then sex selection is not one of them. Okay, except if there is a sex-linked inherited medical condition. Can you give me an example? Hemophilia, where you can select to terminate one a male baby. Okay, but otherwise it's not one of the lawful grounds for a termination. Okay, so it's just one of the keys for discussion. So a couple have undergone a fertility treatment, okay, and an early pregnancy scan shows that there is a twin pregnancy. The couple already have a daughter and tell you that they could not cope with the twin pregnancy and are concerned about the risk associated with twins. And we do know that twin pregnancies carries its risk. It's risky as compared to the singleton pregnancy, right? So they requested selective termination. So they have twins, and they said they already have a daughter. They're not happy about the twin pregnancy because of the risk. At their scan just before the selective termination, they asked that a male child should be preserved if possible. This was their request. Okay, so now this is a conflict. This is an issue. How do you deal with that? So what was the first step? That you need to identify what is the conflict, what is the issue, what is it in between, right? So the issue is between a couple and the fertility team. Okay, so what is the couple saying? They don't want the twin pregnancy and they want the selective termination. What was the fertility team verdict? They said, before actually giving the treatment, like in any other case, they have warned patients that twin pregnancy will be the risk. There can be a twin or triplet pregnancies, right? Multiple pregnancies, the risk of fertility treatment. Okay. And they think that it is appropriate that they're asking for termination after she's become pregnant. Either you don't go for the treatment if you know the risk is there, and why she's asking for termination. However, patient is also right that now she's pregnant, she's got twins, and we all know that twin pregnancy is a risky pregnancy, and there is always an option to terminate one baby, so as the other baby singleton pregnancy can continue. So this is a conflict between the two parties. What do you think so far?
They mean that like when pregnancy or sex selection.
Yeah. They mean what, sorry? Yes.
Why we have a right to do everything.
Yes.
Why do we
No, sorry, what's your, I don't understand what you're saying. Can you say it again?
When did they do it?
Yeah, I think 24 weeks. I think so. What was that?
That they were doing pregnancy or 20.
An early pregnancy scan, which is, I don't know, it's 12 weeks. I don't know, 12 weeks maybe. There's no research. 12 weeks or maybe 14 weeks, yeah, whatever. Early scan. Does it make any difference? No.
One of them.
Should we apply the principle of should we apply the principle of ethics that we discussed? Okay. So let's see, autonomy. The first was autonomy. What does autonomy mean? The patient has a right to choose, right? The patient has a right to choose what they think is best. Okay. Then comes what? Okay, first of all, identify the conflict, which we have identified. It's between the patient and the fertility team. Autonomy means the patient has a right to make a choice. Okay? But the doctor also has a right to not to carry out the procedures that they objected to. So both parties have a right to choose. Also, the team felt that they actually counsel the patient beforehand that there can be risk of multiple pregnancies. So it's not very. You can lose other. Yeah, we'll come to that. Very valid point. Very valid point. So which means that you can do the harm to the other baby. Okay, so non-maleficent. Beneficence, yes. Pregnancy can continue successfully if it's a single pregnancy. Okay. So when she was sent to the fetal medicine unit, and the person, the specialist over there, didn't do it because they were asking to terminate the male, they were asking to terminate the female child, the baby. Okay. And what is the justice? So no request like this has been received before in that hospital. So there was no principle or there was no guidelines to follow in that hospital. Okay. But we have discussed the battery is running low. Just time. Do you want me to put it in there? Okay, I'll do it. I'll do it. It's okay. Okay, so for the second opinion, they asked to preserve the male baby. So what was the outcome? At the end, the request was denied. And why? Because the fact is that sex selection is illegal in UK.
Illegal and unethical.
Unethical also. Okay.
Human rights statement regarding
the sex selection thing, yeah. But the unborn child doesn't have any right. We know that. Yes? Unborn child doesn't have any right. But you cannot terminate, or you cannot just on the basis of sex. It's just unborn child. We're not talking about male and female. But if you're terminating a pregnancy or a child on the sex, on the basis of sex, then that's not acceptable.
Even I just discussed it during revision last Saturday. Even during pre-implantation genetic diagnosis, it is not legal to choose male or female in UK.
And there are some private centers in other world where you can go and choose it. Not in UK, but there are places where you can actually select this, and there are private places, and I don't know where their places are, but you must have heard of Victoria. No. So I don't know, somewhere in America.
In Egypt, no, and for pre-implantation genetic diagnosis, but actually I refused to do any.
Yeah. Okay. Do you think, my question is, if they have requested a termination and not mentioned the male child, do you think we should terminate her pregnancy? Then she has.
We need to discuss that.
Yeah, obviously, yes.
And she will.
Yes.
In UK, mostly she will tell. She will not lie. In most cases.
I think, let's forget about the IVF. Okay, let's talk about the twin pregnancy. There is a very valid point when we discuss risks with the twin pregnancy. There is a discussion whether she can selectively terminate one of the babies.
Yes, you are speaking about twin.
Yeah.
Yeah, I think it's justified for triplet, but for twin, it's a balance.
It's a balance.
The balance will come with confirmation of twin, then termination.
Then risking a baby, which is the one you continue.
But in triplet, for sure, this
triplets
market improvement for the
So my question was whether you will terminate or not if it's not on the basis of sex. So you see, it's not very clear, these ethical issues, and these, when they come, you really need to look in each case individually, because there's so many. In this particular patient there was IVF. In this particular patient there was counseling beforehand. They have a daughter before, and they wanted to have the male baby, and this and that. So every case is different. So when you're applying the principle, ethical principles are very different from the published laws and guidelines and protocols and rules. You cannot apply one principle in each case. Right, okay. Okay. So coming to the consent. Consent is also an important part of the ethical ethics of the medical.
The Abortion Act.
I didn't, because I thought termination of pregnancy is a separate topic. No, I did discuss Abortion Act, but I didn't discuss the clause and just the clause. Is it? Do you do it as a separate topic because it's?
Yes, but I think we can also relate it to the common. The common act is C.
The common clause is.
The common clause is C,
yes.
Which may vary from
the social reasons. Yes. Yes. I mean, I wanted to just cover the legal aspect of termination, but the clauses, as I said to them, please read those clauses, the reasons to do termination, and they are very, very important. They will come in the exams. Okay. Right. Consent. Consent is also a very important informed consent is a key factor in modern ethical medical practice, and great emphasis is upon it. Do you take consent here from your patient when you do operations? Do you have the consent form or what?
Yes.
You have the consent. Who signed the consent form? Patient? Has to be there.
As for our hospital.
Okay. Right. But who signed the consent form?
Both.
Okay. Right. Okay. Well, it varies. I reckon it varies from one hospital to another hospital. But anyway, I mean, it's interesting to know that when we're talking about an autonomy, which means that each person has a right to choose what they think is best, and why the husband is signing on behalf of that patient. And it's again, it just highlights my point that the culture values differs from one society to another society. And you got to respect that values, okay? I think it's fair, according to your culture or according to the place and according to the values, that yes, husband should be there if the wife is taking a big decision of her life. But whether he should sign the consent form on her behalf is, I think, not right, okay? So, because when we're talking about autonomy, then each person has a right to do what they want to do. Okay, and we will talk about the capacity in that respect, which means that how do we know that that person is capable of understanding and signing, giving the consent? How do we know? And that is what called capacity, and we will talk about it. Okay, so informed consent is a very key factor. So there are different kinds of consent. So you can take verbal consent. Okay, you can take a written consent. There are two types of consent. Not for, you don't need written consent for every single thing. Okay, it's only for the big procedures. It's only for like terminations of pregnancy and operations. You need the written consent. For other things, you do need a consent, but the verbal consent is enough. For example, if you are putting a cannula in patient's hand, Venflon or cannula, obviously you need to ask the patient, right? You cannot just go and shove the needle in the patient. But that's like a verbal or oral consent. Can I do that? You're taking bloods from the patient. You're sending bloods from the patient. You do need to take the consent. That's not oral, but that's not written consent. You don't need a written consent, right? And there are two ways you can look at the consent. One consent is from the clinician point of view, and the other consent is the patient's point of view. So why clinician need to take a consent? Do you have any idea why they? Exactly, because what he needs to make sure is that he explains everything to the patient, including the risks, so that he or she can protect himself or herself from a charge of common assault or from any charges later on, right? What is patient-centered consent? And that is more important. And patient-centered consent means that you need to discuss the risks, you need to discuss the procedure, you need to discuss the risks, you need to discuss the benefits of the procedure, plus you need to give all the information regarding the procedure or the treatment so that patient can make informed choice. That is important. Just signing the consent form will not protect you in the court. Why? Why do you think? Yeah. Okay. What more important is you need to make sure that you've given all the information to the patient. That is the most important thing. Okay. Okay, so what are the so the procedure itself, you need to tell the patient what you're going to do. For example. Okay. So on the consent form, you need to write down. Number two, what are the benefits? Why are you doing it? Okay. Sorry? So what, give me some examples. Well, what would you tell the patient? If you're doing it for whatever. Okay, let's say she's suffering from anorexia. Yeah. So you write on treatment, and this is one of the treatment of anorexia. Yes, hysterectomy is one of the treatment of anorexia. But do you think that would be enough? So that is the benefit, okay? You have the treatment. Okay. Let's come to that. What are the risks? So you list down the risks. So first you write down anesthetic risks and then surgical risks. You don't need to explain too much about it because the anesthetist will come and see the patient, and that's her duty or his duty to explain the anesthetic risk. But you obviously just write down anesthetic risk. Surgical risk, so starting from, always start from bleeding and infection. Bleeding and infection are the universal risks to any kind of surgery. Okay, whenever you are explaining the risk of any surgery to the patient, always start from the minor and then comes to the major. You're not trying to scare the patient by saying you're going to cut your blood. Yes. So say bleeding and infection. When you're explaining the breathing infection, always say, this is more important than what I'm telling you is from OSCE point of view. So when you say breathing infection, then say breathing infection are the common risks and they happen with any kind of surgical procedure. And they are common, but they are more easy to deal with in such as we take bloods beforehand from you to make sure that you have arrangements made if you need any replacement at the time of surgery or after the surgery. That's how we deal with the infection. We say we give you antibiotics before the procedure, right? In UK, there is no routine antibiotics given after the hysterectomy. Okay, so what we say to the patient that we'll give you antibiotics before the procedure as a single shot before the surgery starts. After the procedure, if you start running any temperature, if you start feeling unwell, even in the hospital or if you go home, then we will advise you to take some antibiotics, either by the GP if you go home, or if you are still in the hospital, we'll give you there. But otherwise, we won't give them routinely, right? As you're explaining the risk, you need to be telling what you're going to do about it. You cannot just say this, and say, there's nothing I can do about it. This could happen, but you have system in place to deal with those complications. Otherwise, I would not go for a hysterectomy if you're just explaining me the risk and not telling me what you're going to do about it. Okay? So, bleeding infection, injury to the bladder, bowel, and urethra, and surrounding structures. Okay? You say that this is the major risk. These are the major risks that can happen with total abdominal hysterectomy, but they are very rare to happen. The chances are about, 2 to 3,000 or 3 to 4,000 cases or something, whatever figure you want to quote. You need to quote something, okay? These should be on your fingertips. So these are the major risks. They are very rare to happen. But if they happen, okay, if they happen, we usually know at the time when we are doing the procedure, while you are still in victim, and we'll try to repair it there and then. But of course, you may know it after the procedure, eventually, after 2 or 3 days that something has happened. Say that usually we come to know about this in victim, and we'll do something about it. We'll prepare it. But that does mean that we will be spending a lot more time in victim than the movement section. Okay?
So you said that if patients find the consent of the interest which you're needing there.
If you have written all these things on the consent form, in the consent form, have you seen the consent form from UK? Yes, there is it's a format. It's a format. So name of the procedure, benefits, risks, and he said she needs to sign the consent form and you need to sign the consent form. Okay? That's done. Okay, that's done. If you have written all these things and patient has signed the consent form and you have signed the consent form, it's always good practice to actually write down in the notes as well that you have explained this to the patient and patient agreed to have the treatment. Okay? So this thing is more important than patient signature. Okay? If you have not written any of those and you get the patient to sign the consent form, you cannot defend yourself in the court, but there is a patient signature.
If there's some deviation from the consent, for example, whether there be elective CS, happened that she entered in her own report, and you had that decision after doing everything that you will do with that. Should I go outside and let her relative know
Well, look, what is
I didn't write it.
okay, what do you take the consent for hysterectomy and cesarean section for every single cesarean
No.
section? No.
This case happens to face this problem.
Okay. We do take consent for hysterectomy in special cesarean sections, and those are placenta previa, placenta creta. We do multigravida.
Yeah.
Okay, because there is a risk of postpartum hemorrhage. Even though if you had 6 normal deliveries, if you're taking her cesarean section for whatever reason, there is a very high chance. So you take the consent for total abdominal hysterectomy. And you say that there is a risk. And say we'll try and do everything before that. There are a lot of things that we can do, starting from the drugs, starting from the drips, starting from the Beelan suture. So we need to discuss and write down. We need to discuss and write down. And how likely? How likely it is? We don't take consent for hysterectomy.
But you are not obliged to leave the user and go outside to the lens and say.
What is your duty as a doctor? What is your duty as a doctor while you're to save the life? So that particular procedure you're doing in saving life of the patient. That is very different from the rest of the things. Okay? If you are acting in patient's best interest. And saving life of the patient is very different from, oh, actually, you know what, I saw a cyst and I saw a big fibroid, so I decided to take the uterus out because there is a big fibroid. No. Okay, this is very different. You're saving the life of the patient. Right? Okay.
If I found the fibroid or
Leave it. If you've not consented, leave it. Okay? If you're trying to be a bit more heroic and you're trying to take a cyst out and then there is a bleeding and you end up taking the ovary out, how are you going to defend yourself? Was that cyst risky to her at that time? No. You can always bring her back in, I don't know, 2 months' time, 3 months' time and do a laparoscopic cystectomy. And explain everything. Everyone is your own. I'm just saying. And then because then you'll be explaining to the patient the risk of cystectomy, which is that she can lose her ovary first. Once you've explained it and things go wrong, that's okay. But if you've not explained it and unexpected stuff happen, then you cannot defend yourself, right? Okay. In some hospitals, they have the stickers. What they do is the form is the same in all hospitals, but they have the stickers for the risks or the benefits for each procedure. So what we do is rather than writing, we just put the stickers in the special columns. I prefer to write whatever I discuss. Yeah. I write everything on the consent form. Now, the other thing you must not forget, and that will make the consent as informed consent. It's different from normal consent. Informed consent means alternative. You have discuss the alternatives to the patient. For example, we are doing a total abdominal hysterectomy, okay, for a patient who is suffering from menorrhagia. You've already written here. But if you must write here that she has, you must write here that you have discussed that there is a failed medical treatment. She has already used progesterone. She's already used, what are the other stuff? Mefenamic acid. So failed medical treatment, Mirena coil, tried, I don't know, in the past, whatever. Or even if not tried, but these options, Mirena coil, have been discussed with her, whether she wanted to have, she refused to have that, or whether it failed, whatever. So when you put the alternatives, when you put the alternative option discussed, that will make a consent an informed consent, which means the patient actually knew about the choices and alternative options before she went for abdominal hysterectomy. Okay, I'll give you another example. You take consent for tubal ligation, bilateral tubal ligation, yes, sterilization. So what are the important stuff when we take a consent about sterilization, for example? So let's start with the same principle that we discussed. So first of all, procedure. How do you write the procedure on the form? What do you say?
Immunization, sterilization of
So I tend to write bilateral tubal ligation rather than sterilization. Okay? What are the benefits? Permanent long-term method. Avoid using more contraceptions, whatever. What are the risks? Bleeding infection, good. So always start with the more common ones. Failed procedure for the laparoscopy, okay. Okay, what else? If you have not mentioned that one, you will be standing in the court. Failure rate. What is the failure rate? What's the failure rate with? 2%? 0.2%?
1 to 200. 1 to 200.
Thank you very much. 1 to 2 per 100. Okay, so 2 per 100. 2%. Okay, which means that in every 100 sterilization you will do, 2 will fail. Okay. What happens if it fails? What are the other risks? Ectopic. If you have not mentioned these risks, you will not be given any marks if this comes in auscultation, or you will be standing in the court. Okay? Recanalization of the tubes can happen. Okay, it's very rare with the clip method, but with old methods, it can happen. And the last thing, so benefits, risk, alternatives. So that's what I'm saying. It's so important that you have discussed the alternatives. So what are the alternatives? Vasectomy, Marina. So why vasectomy? Because not acceptable, you write. We have discussed with her, but that's not an acceptable option. Okay, that's good. Marina? I don't know, failed, not acceptable. She doesn't want a formally. Oral contraceptives, not like tablets. Okay, so when you discuss the alternative, this is so important, because if some complications happen during the procedure, she might go into the court and she said, well, actually, I've never been given a choice of Marina. I would have gone for Marina if this would have been discussed with me. Because surgery carries its risk, and you should not do unnecessary surgery. And that will make the consent as an informed consent. Okay? Okay, age of the consent. The Family Law Reform Act 19. Now, you need to know about all these acts. Okay, so the Abortion Act, the questions will come onto those laws on those acts. So write down those acts on one piece of paper and just write what this act or what that law is about. Right? So Family Law Reform Act 1969, it states that the age of consent to medical treatment is 16 in UK. So at what point an individual become autonomous? So the law says that 16 and over can take their consent. So baby cannot be autonomous, right? An adult become autonomous after 16. But what happened between 16 and 13, 16 or the baby? What happened? Because uh, that age, during that period, they are developing the autonomicity. Yeah, we'll come to that. Okay, so what we're trying to say is that the Children Act 1989 deals with the following issues in children under 16. So where the parent's responsibility comes, where's the parent's right in that case if the patient is under 16, if the patient is minor? Providing the services, protecting the children and looking after children away from home. So this law actually covers all those issues with the children that are under 16. Because over 16 they can give consent. Okay? So now the presumption is that parents can take the decision on behalf of the children because they think that this is in their best interest and they are their parents. Then you must develop the partnership with the parents. You must involve the parents because you're also thinking about the benefit of the child. And the parents are also thinking the benefit of the child. You may differ from each other, right? In that case, it is very important that you make a partnership with the parents. You make them or try them to understand what is good for the child. It's again coming to a decision through a systematic way. You cannot just say, I'm a doctor, I'm thinking best for the child, and therefore I can override or I can overrule the parents' right. Okay, and similarly, parents as well. They cannot just say that we are the parents and they can just do what they want to do with their child, and they cannot force you to do something with the child if you think that that's not in the best interest of the child. Right? Okay. Right. So you need to know about those Family Law Reform Acts 1969, the Children Act 1989, and then you need to know about the Fraser Guideline and Gillick Competence. This is very, 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 very important in the consent topic, and a lot of questions comes onto that. So please try and concentrate before we go on to a coffee break. Right? So when we are trying to decide whether a child is mature enough to make decisions, people often talk about whether the child is Gillick competent or not, and they look at the Fraser Guidelines. It helps us to balance the children's rights and wishes with the responsibilities to keep children safe from harm. Do you know the story about the Fraser and the Gillick, where it has come from? You don't know? Okay. Now, Gillick competence, the name is given to a case, Mrs. Victoria Gillick in 1984. No, 1982. Yes, 1982. So where does this wording come from? So Miss Victoria Gillick had a daughter who was 13 years of age. And she went to her GP, and the GP prescribed Abban. There was no law at that time. The GP prescribed contraceptives to that child. She actually took the local health authority, the GP, the Department of Health, and the social services, all of them to the court, and said why my child is given contraception without my advice. Okay. So, so at that time, according to the law, which was 1969, that children over 16 can give consent. Okay, and at that time, there was no law for the children under 16 at that time. 16. The daughter was 13, so less than 16 years old. There is more than 16 or 16, they can give consent. She cannot challenge, but her daughter was 13. So she took 3 regulatory bodies to the court. Why my child was given. And her name was Mrs. Victoria Gillick, and that's why it's called Gillick. That case is so famous, it's called Gillick competence. The High Court listened to the case, and they said, well, actually, it was, they give the decision in the favor of a general practitioner. Okay, that because the general practitioner has written everything in the notes, that I think this child is competent enough to understand what are the risks of contraception, what are the benefits of contraception, and because the risk of continuing the pregnancy was more as compared to the risk of giving her the contraception. Yes? No. She was sexually active and she wanted to. So which means if you don't give her contraception, she may become pregnant. Obviously the pregnancy at 13 years of age carries a huge social and the medical risks and everything. So what he has written in the notes that first he assessed the capacity and the competency of the child, and he believed that she is well able to understand the risks and benefits, and plus he believes that giving her the contraception was less risky as compared to not giving her, in which case she can become pregnant. Right? So the High Court has given the decision in favor of the GP. She appealed against that decision, and then she won the decision in favor of her.
Yeah, she won it.
Okay, let's finish this, right? So she won the case, and it becomes so famous and challenging that eventually that case was taken to the House of Lords, which is the highest court in England, a parliament, where they discuss very difficult issues and they make laws. And at that time, the three judges, one of the judges was the Fraser, Mr. Fraser, and that's why it's called Fraser Guidelines. In 1985, when this went in the House of Lords, they reversed the decision, and they said it's the same as the High Court law. And then they made a law onto that. Okay, and they made a guidelines, and that guidelines are called Fraser Guidelines. Okay, so Gillick competence is when you are assessing a child, whether the child is competent enough to give the consent, and Fraser guidelines are then based on that case. Okay, so what are the Fraser guidelines? This is the Fraser guidelines. Okay, so in the House of Lords, on the basis of Gillick case, Mr. Fraser has made a law and developed the guidelines. And that is that actually under 16 you can give the treatment, this was especially with regards to contraception. If the GP can satisfy it with the following criteria, that the girl will understand his advice, he cannot persuade her to inform her parents or to allow him to inform the parents that she's seeking contraceptive. So it has to be confidential. You have to win the trust of the patient. Right? You can obviously encourage her to involve her parents because this is a big decision, but you cannot pursue her, you cannot convince her, you can encourage her. That's very different. Right? Don't try to convince her, try to encourage her. Okay? She's very likely to continue having sexual intercourse. So if you are convinced that if you don't give her contraception, she will still continue with the sexual intercourse, and there's a risk of her getting pregnant, and it will affect her physical and mental health and everything. And this is in the best interest of the patient. Right? So remember Fraser guidelines, where it has come from, what is Gillick competence means. How do we assess the Gillick competence? So this is the criteria.
How do you assess that she's competent form?
No, you discuss the risks, you discuss the benefits. The judgment lies on you. This guidelines, which means that you are satisfied as a doctor. Okay, and the first thing is that you got to be honest as a doctor. Honesty is one of the GMC, the duties that GMC had laid. Right?
Guidelines and before, is that I can convince her to take her parents. If she refused, I will give her contraception.
Before, what do you mean before? We use these guidelines, yes. This is for everybody, not just under 16. But if you have a child under 16, you still need to, age over 16, you still need to discuss the risks and benefits with her. Okay? You still need to encourage her to discuss with her partner or with her family or whatever. Okay? You will not be challenged in court if you are giving contraception to a person over 16. But you will be challenged in court if you have not filled all this criteria. Because what is the age for consent? 16. Okay? The parents can come and sue you if you have not satisfied with this criteria and you're giving contraception under 16. Obviously, with any kind of consent, age is not just a factor to assess anybody's competence. Do you understand what I mean? Because if age is a factor, then we should not be discussing this under 16 for children under 16. So age is not a factor. Okay, this criteria has to be met. You can still give contraception to children under 16 as long as you have met this criteria. You are satisfied.
But we need to take care that below 13 it's illegal to practice sex. So it is not applied for below 13, especially if the mental capacity or there is any suspicion.
I think if there is a question about the capacity, we'll come to the capacity and competence. How would you assess?
But it's then.
Oh yes, I mean
it's 12. It's just approaching 13, and she is
yes. I think
problem.
Then it's a very different issue. Then it comes
but by law,
dealing with minors.
13.
It comes involving the social services because she is a small child and she's involved in sexual activity. What's happening with her, right? Is there any person? Then you really need to assess who is she with. Is there a person? How old is he, or what's going on? Because with the child under 13 or so, surely it should not happen.
Any question? For the favorite airline? At the age of 15
Yes, yes. As long as you have met the following criteria: that you know she's competent or she has a capacity to understand. You've explained the risks and benefits. You have encouraged her to discuss with her partner or parents. Okay. You have also. Oh yeah. It's okay. That's what I'm saying. Don't try to convince her. That's not your job. Encourage her. Okay. Offer her support. Okay. Offer her support. So what is a valid consent? When do you say the consent is valid? It is appropriate. When someone give it voluntary, when there is no pressure on somebody. Okay? When it is given by an individual who has a capacity, that's what we are talking about. When he has an understanding of what are the risks and benefits. Is given by an individual who is fully informed. Very, very, I've put in red those things because fully informed, having the capacity, fully informed means we've also discussed the alternatives, not only the risks and benefits. Okay? Okay, just to tell one question and then we'll have a coffee break. So always read the stem very carefully, and what they said is that what are the things, which of the following criteria would you think are strictly necessary to confirm the validity of the consent? So we've just talked about that in the last slide. Does the procedure. So do you think if you are doing, if your consultant is doing the list and you have gone to take the consent, so you're not doing the procedure, so that is not necessary. So why are you saying this is true? False, you meant false. Okay. Okay, so that's not strictly necessary, right, for the valid consent. The next one? True. So the patient must be competent, and that's what we talk about. The patient should have a capacity to understand the risks, benefits, alternatives to make the consent valid. If the patient is not competent and does not have the capacity and you take her signature, there's no point. So this is strictly necessary. Okay? False. Because age is not the factor, right? It's the competency we are talking about.
Over 60, also? No, yeah, so she must be over the age of 60.
No, because we said for the contraception, you can still give the contraception under 16. So age is not, as long as that person is competent. And competency is different from age. Right? Yes, true. Because there should be no pressure. It's voluntary. Okay? If the patient is unconscious, a blood relative must consent. False. What did I say about autonomy? That each person has a right to make decision on his own. A person is unconscious. The blood relative cannot take the decision. You as a doctor need to take a decision in the best interest of the patient. And what is the best interest of the patient? As you said, we do the hysterectomy because you are saving the life of the patient. If you go out and discuss with the blood relative and he says, I don't allow you to do the hysterectomy. Okay? So the blood, no one can take the consent on patient's behalf. If the situation comes when the patient is unconscious, you need to take some decision. It's the duty of the doctor to take the decision in the best interest of the patient.
But if she has,
Yeah.
I think you will discuss after break lasting power, coronary and advanced direction.
No, I didn't take it from your presentation,
Okay.
but I think what is in your presentation we can discuss with that.
Yes, no problem.
Yeah, we can discuss with that. So there is one point that Dr. Ahmed very validly mentioned is that no one can take a consent from patient's behalf and patient is unconscious, okay? But if the patient has given a consent to you before they become unconscious, and then
This is called what? Advanced direction. Like you have it with this.
Yes, I will explain to them. So if she has made a decision before she was unconscious, whatever the situation is, you must respect. So when we are talking about Jehovah's Witness, okay, what is Jehovah's Witness? A person who refused the blood transfusion, okay? So she has very clear, and there is a form, there is a paper which is called Advance Directive, okay? That paper is called Advance Directive, and every person, Jehovah's Witness, should have that form in their notes when they are coming to the hospital. Okay, what that form involves is the discussion about what products will she agree to have it, because some Jehovah's Witnesses say we do not want the red blood cells, but we are okay with plasma, we are okay with white blood cells, we are okay with platelets. But there are some who say actually no, I do not want anything. So that advanced directive is something that should be in their notes, and there should be a signature for the patient, and you should tick what has been discussed with the patient. Because whenever she comes in any situation, you must look at the advance directive. If you're going to perform a procedure on a patient with Jehovah's Witness and you have not put advance directive and you have not discussed, you will be in court. Okay? And in that advance directive, there is also an option of you will give what you call she's happy to have iron infusion. She's happy to have oral iron tablets. She's happy to have what you call the drips that stop the bleeding. Thrombin factor 8 or something like that. Okay, so there is a list of all the things, factor 7, factor 8 or whatever. So there's a list of all the things in advance directive, and you must put it in the notes for the Jehovah's Witness. Okay, so you take everything and you put it in the notes. If that patient becomes unconscious and she's bleeding to death, you cannot give her the blood. If that's what she has consented, you just cannot give her. If you saved her life, you've given her blood, you will be penalized in court for saving her life. That's how serious it is. Okay? So, and similarly, if the patient has said that she does not want to be resuscitated, she's a end-stage cancer patient, and she became unconscious and you resuscitated her, you saved her life, but you will be charged in the court. Why did you do that if when she consented she does not want to do it?
Is it that some schools and I have the right not to be...
She has taken her decision at the time when she has the full capacity to take her decision. Okay? She has the full capacity to take the decision that this is what she does not want. What you're talking about is the Mental Health Act, and it's a very different thing about the mental problems. And in that situation, patient does not have the capacity to make the right decision. Okay? Antidepressant, but again, it's the person who is seeing that patient need to assess her capacity. If there is any doubt about her capacity of refusing a treatment or competency of giving a consent, then you need to contact the other authorities. You may contact the court, you may go to the social services, you may involve other people. Okay? If you are in doubt, and that's your duty to assess. In refer to psychologist. I mean, if you are not sure that it's not up to the psychologist to assess her capacity. It's your duty to assess her capacity. If you want to refer her for a treatment to a psychologist for her mental condition, that's something different. But you cannot refer her to a psychologist to assess her capacity. That's your duty. Okay? The patient must have received sufficient information. That's very important. That's how it makes the valid consent. Do you want to take a coffee break and then come back? Yeah? Okay.
It doesn't have to be formal because maybe we're 100% from the business. So it should be forced. It doesn't have, unless the head of the patient says to content the consent taken from the patient himself.
Okay, I think the report about the patient was yes, but you know, there is, if you're talking about the cases where parents need to give the consent, there are different kind of consent. It's not the same consent.
But still valid.
That would be valid. Yes, that would be valid. But you know what? When you're trying to answer the question, try to make it simple. Think simple and think more commonplace, rather than making it more complicated. If they would have been talking about the one this knowledge that you are talking about, they would have mentioned it instead.
I think the patient should say the consent taken from the patient.
I think this is the question. Otherwise, they would have been mentioned about the parents or the age under 13 or something like that. This is what we're talking about an adult.
So, I think simply unless you mention
Yeah, that's
otherwise.
the mention. Yes.
How many days from morning to night? How was it? Even me, I am sorry, but I should come because you are thank you. It's not very difficult exercise. Just try to understand. Go home and read the terms and questions.
دكتور أحمد دكتور أحمد
دكتور أحمد
دكتور أحمد
دكتور أحمد is not here.
هو في بريك دلوقتي بريك
في بريك
ده بريك
ده بريك.
طيب شكرا شكرا شكرا
انا عايز لا انا مره الصبح لا الجهاز ده الخط اللي انت فيه
مكنة الصغيرة المحاضرة بتاعتها اللي فاتت.
ايوه ما خدناش. انا اقول يا دكتور احمد ما خدناش. انا ما حضرتش المره اللي فاتت. انا جبت كل الاسبوع اللي فات الريفيجن كورس والقصه بتاعتها والله. يعني الكتاب الجديد اللي جوه لا عينك ولا لسه انا مش عارفه مش انا جيت قلت اقدم عندنا زمان الاسبوع الجاي وكده. ايوه اوكي الدكتور عايز نزلني نايم. لا ما انا اقول تعالى عندنا بنات بس نايم ان شاء الله. قال لي ما تبقي طالب زمان تنزلي. لا تنزلي لما تيجي توزيع في الزمالك في بوي تدخل تيجي للعيال كلهم ولا دي مش صعبه خالص. تيجي عندنا مستشفى قلت لا في مستشفيات كتير وفي امبابه وكذا مستشفى اللي فيهم راحوا زمان انا رجعوهم هناك. احنا عندنا لا يعني ربنا يهديهم علينا لحد دلوقتي ما اعرفش نرجع تاني اخد حاجه الساعات دي. انت النهارده معيطه كتير انا معيطه وانا انا بس مش لقيت اللي هو بسأل كده عليهم لا وليه انا شايفاها ايه شايفين كله انا كله انا عايزه حتى لا انا عارفه انا عايزه لا كده تعملي ايوه دكتور ماما بتعمل للاسف يعني انا مش هو دكتور يعني ما اعرفش مش شايفها قالت لي ما تبقاش فيها كسره هي معاها وصلت كمان انا ما اعرفش ان انتوا كده انتوا فبعدين قال لي انت صغيره وانت صاحبي انت صاحبي كل صغيره كده لا ده مورد الليزر اللي بينزل التفسير ده بتاع بكره اللي محتاج كده وتعمل كده اي ده لازم عمليه. انا كمان انا فرمتي المرات دي ايه وبعدين هو الحته دي انا عايزه اصور الفيديو بتاع الكتاب ده اعرف وانت ولا مش عايزه استخدم ده تقريبا جديد مش ما عنديش من الدكتوره ده بتاعي لا برضه ان هي معاك ده
بس دي بتنام بضربه على قلبها عشان طبعا تعالي نقعد كده بقى ورا انا هذا الشخص انا هي فين ام مريم؟
مريم النهارده تعبانه
ليه ما جاتش؟ تيجي برضه
والله تعبت 3 ايام ورا المراجعه دي
بس
التانية كمان يعني تعبانه.
هو انتوا طالعين الطلعه دي؟ بتاع 9 دي؟ تخش
لا احنا اللي حضرنا المراجعه كلنا يعني يمكن في عماد بس كان في كان اسمها كريستين داخله من قبل وحضر بقى كلنا احنا مش فاهمين مش واحد يستفيد يعني
كده وعليكم السلام ورحمه الله وبركاته. سعيد جالك حد؟ امبارح؟ ليه؟ هو مسترد الجمعة
سعيد
يا واد خالد الجمعة دي
لا مش دي الجمعة الجاية. الجمعة دي عشان هو مش هيعرف يجي الجمعة الجاية.
نزلت طابة ده الواد ما سافرش المرة دي عشان كده. أبو أفكاركم يعني ألحق أكلمه والله هيفوت عليك. غالي عشان لو هيسافر يسافر. مسافر هو مسافر المنصورة يا ابني. ايه بقى؟ انت متأكد ان التوتاني ده هيجي بكرة؟ توتاني جاي بكرة؟ مين توتاني؟ نمرته ايه عشان الموبايل يجي؟ احنا بقينا كام ناس؟ ما شاء الله لا قوة الا بالله. عندنا خمس شباب؟ شاي ولا قهوة؟ عندي خبر حلو وخبر وحش. ركز يا ولد علشان تفهم اللي انا هقوله. اولا انت مش لازم تيجي بكره. بس لازم تيجي يوم
بصوا الناس تقول لي ما فيش مشكله ما انت معاك كتير.
عشان انت حبيب قلبي يا خلود يا طعامك يا قلبي، عشان انت قلت لي عايز تسافر عند مامي فانا بقول لك روح. لا في واحد اسمه مش فاكره ايه، بس انا لسه دلوقتي لابسه تشريح فهمت منه القصه دي، ان في واحد جاي فمش هيعرف ياخد اخر جمعه البتاع، فانت تاخد اخر جمعه. انت شاطر شاطر والله، هتقول لي طيب وحاضر يا مامي وتبقى شاطر. لا ما تقوليش،
وانا لو عايزه اقول
لا ما عنديش حاجه خالص. خلاص لبسته كده صح؟ كفايه كده لبسته صح؟ خلاص انا لبستك كده
مش عايزه اقول لوحديها بقى. مش عايزه
قول خلاص. طب وانت معايا من حد؟ لا 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 كده كتير عليا، كده ممكن اندمج. مش قادر اللي كان عنده ياخدوا ميه ويا والله افرجك تجيب لك جيلاتي. بضرب الثاني ساعتها لما تجيب عضله عملت اسبوع عايز بتكلم معاك بكلام السلف سوتني السلف يقول لك سوتني اسم السلف وهيجي جمعة هيجي بكره وانت قلت يعني انت ليه هتفتح العربية وتجري عليك بيقول لك ايه هو انت على طول العربية عملت ورقة ايه الحلاوة دي؟ يلا بقى نمشي عشان انا ومخلص نكلمك. انا تعوضونا بقى يلا واحدة بقى. نعم بقى من الجزء عايزة
الرد منطقي يعني عارف
لا عايز تيجي من الصبح لما خلص النظام الحديث بتاعتك
طبعا
واحتمال يبقى مع الجوله بس لو عايز تدخل الجوله ممكن تيجي تعالى خدي راحتك خدي لك قلم جديد كانت رحله للزيت يعني هو انا لسه مسكوك معاكي بنفس الوضعيه الدايره يعني ولا ايه؟ ده بيقعد مع الشيء ولا ايه؟
هم موفرين بس احنا بنعرف بس لو الرئيس الاسم عدى واحنا أول مرة أنزل يعني أروح أنا مرة كل أسبوع لازم أروح أتجوز على يعني مش مستغرب يعني نفسيتنا على خبر كلمة دي موضوع على فكرة دي عاوزة وقت مامو
انا حطيت كل الفاهم
ان شاء الله ولا ايام ايه انا اجي معاك
You want to have a coffee or something?
Do you like to eat?
No, I had a coffee. I'm just taking it. So how's the plan? Dr. Amin, you told me about the date.
Yes.
I think it should be okay. In October, you said? 29th October. It's Saturday, yeah? We'll maybe meet up again to discuss how. I think we need to
more today.
okay.
I can prepare
I have also another on 22. I have the basic certificate. Also want to share.
It's again on the weekend.
No, 21 also on Saturday.
Okay. That is option. Right. Okay. Sorry.
It will be for level of undergraduate.
I know you've been doing it this time. This was the one.
Mission, actually, I find it like
Sorry, you had some question. No, it's okay. What was the question?
regarding Alex.
After the mission. Okay.
Alexander.
Alexandria. What date is it? I'm away actually most of the time. I will maybe. Which day are you talking about? You said 20. Maybe. Why not in November? Because you are also doing it in October. We can do in November. Because we said it was Friday or Saturday. Is the aircon on? Can we put this on?
مفيش حاجة
Is anyone outside?
كلمتيني يا رشا كلمتيني ده
انا اللي اتكلمت التليفون لوحده بيعمل حاجه دي.
كلمتك بقى بعد كده كان التليفون مقفول.
We are missing some people. Are they coming? There are three. I think there's one here, two boys.
I will see them start and I will see them.
Okay. Right. Okay. You can have your coffee while we are talking. It's okay. Are we clear about so far we have discussed? So we have discussed the ethics, the definition of ethics. What are two approaches that we can use? What are the principles of ethics that we can apply to the different cases? And what is the consent? What is the valid consent mean? Yes, consent is an important part of the ethics. So you've attempted one question as a simple best answer. Okay. So continuing from the consent, I was talking about the mental capacity and whether the criteria for a valid consent is the person should be competent. You have asked me, sorry, you asked me one question onto the, so what's your name? Ahmed. Ahmed asked me a question, me? Okay. He wants to give me a sugar. He wants to give me a sugar so that I can survive the rest of the day.
3 days lectures from
They're telling me.
10 a.m. till about 9 p.m.
That's why some of them could not come because they're just so tired. Thank you.
Most of them didn't attend the revision.
But those who attended, How was it? Was it good?
Yes. And Ahmed attended, but not all time. Yani, he came after 5 or 3.
Right. Okay. Ahmed has asked me a question on this scenario, this one. What was your question, Ahmed? Can you repeat it?
The patient must be competent to take the decision can be false because we can make still a valid consent from the spirit.
Okay. Do you understand what he's asking? Yes. So what he's saying is the patient must be competent to take the decision, and we said that it should be true, but Ahmed said that it could be false because if the parents are giving consent on behalf of the children, if the child is not competent because the child is young. But, so who is giving consent in that scenario? Parents. So do you not think that parents should be competent as well? Yes? So we are asking the question, the one who signed the consent should be competent or not. So whether it is parent, whether it is a child, whether it is an adult, has to be competent. The question is not about the young person or adult person or the person who signed the consent. And whether it's a parent, whether it's a relative, whether it's an adult, whether a child, has to be competent. So do you understand why we say it's true and it cannot be false then? Yeah? Okay. So try and keep things simple in your mind, because if you think simple, you'll
This is for all of us.
Okay. So coming to the mental capacity, we did mention that in the consent form. A person is said to be mentally, to have a mental capacity to make a decision about a certain matter. How do we know that someone is competent? How do we know? How do we assess? Your question was, but how do we assess? That you need to know whether that person can retain the information about the matter. Okay? So the simple thing sometimes is that you explain something to the patient and you ask the patient, so what is your understanding? If she's able to give you that information back, it does mean that she has an understanding of what it is. So that's one way of judging the capacity of the person. Yes? Then you need to know whether she understands what it means. So if you are telling the patient that the risk of hysterectomy is that there could be a hemorrhage, not everybody knows what is a hemorrhage means. You need to explain it in a very simple term. That there is a risk of bleeding, and the bleeding can be so severe that it might risk your life. Okay? But we have certain measures in place to deal with it. And what are the measures? The measures are the medical treatment, the surgical treatment. For example, we're talking about cesarean section, so we have uterotonic, so we have Whelan sutures, so we have whatever, internal artery ligation or whatever. So you need to make sure that she understands what you're explaining, the reason about it in his or her mind. So if she's having, if she's taking one option, why she's taking that option? So if she's going for a hysterectomy, has she considered other alternatives? Right? So what is the first principle is do not do harm. So if you have not given her the option and you're taking her for a major surgery, you're actually doing an harm to the patient. You think you are actually giving benefit, but you're actually doing harm because you've not given her the alternative options. Convey the decision that she or he has made to another person. She's been able at the end of the discussion to tell you what you have told her. That will also show you what is her memory like. Okay? You will be dealing with difficult, if you're working in obs and gynae, it's not that difficult, but if you're working in the other specialty, you will be dealing with patients with dementia and stuff. Okay? You will be dealing with patients who have loss of short-term memories and stuff, or fluctuating memories. So there will be difficult scenarios when you are when you are assessing the capacity or competence of a person.
Can we go them?
Yes, absolutely. That's the best thing you can do when you're taking the consent. I always do that. Not just taking the consent, when I am explaining the condition to the patient, always draw big diagrams, show them, they like it. Okay, they will understand it. Draw the uterus, draw the ovaries, draw the fallopian tubes, where it is, where are the ureters. Show them. This is the best way to explain. So don't use medical jargons when you're explaining in the consent form. Use simple words that they can understand, and therefore the term that understand it, that you don't use medical jargons in that. Yeah.
And for some women who have special needs, there are specific information needed for them for some simple procedures. We can also get consent for simple procedures like pap smear. There are special diagrams for them for pap smear and for simple procedures.
Yes, so in UK, he's very right. In UK, when you're giving consent, when you're taking the consent, what normally happens is that we don't take consent in the clinic when we see the patient on the first consultation. What we do is we give them the information. For example, a patient is going for a hysterectomy, so we explain to them, and then we give them the information leaflet to go home and read about it. You also give them the surety that if she has taken a decision to go for total abdominal hysterectomy, it does not mean that she cannot reverse her decision. Go home and read the information leaflet, take all the information that you have given, and we'll put you on the list, okay? If at any point she changes her mind, for example, after reading the information leaflet, she's not happy and she wants not to go, say to her, you can always ring back us, so it's basically the secretary of the consultant, and we will do accordingly what you want. So the at least patient will have a surety that I can change whenever I want. But say to her, let us know, because then that slot can be given to some other patient.
الريس بتاع بندل الاوبريشن ولا ريسكيدول اوبريشن فاكر حاجه بتاع
هذا الفورميليشن بتاع السؤال والفورميليشن ده كان او ممكن اي كلمه فيه ممكن تغير. لما جاوبناه على الفورميليشن بتاعه. دلوقتي انا لو افتكرت في الشاش كده ممكن ابوظ.
يبقى نفس السؤال ده ريسكيدول
You can't tell her about. You can't tell.
Can I ask now?
Yes.
Yeah, please.
There is a question about patient. She consented about doing the total abdominal hysterectomy. Then when she comes for the operation, she changed her mind.
Yeah.
And in the options, there is two options. Either we abandon the operation or abandon the operation and reschedule for another time. I want to know the difference when we choose abandon the operation and when we choose and reschedule.
Well, if she doesn't want it, you cannot reschedule it.
In the scenario of the question, we told that she is not sure about her decision.
You cannot reschedule it. You need to give her a consultation back in the clinic. You need to bring her back to the clinic, and then you need to discuss things again with her. You cannot just put her on the list if she's not sure.
So
yeah, she has to be.
Operation
yes. No. Another time. After discussion again with her, give her a consultation appointment in the clinic. That's something you definitely need to do for her. You cannot just forget about her and send her home. No. You offer. If she accepted, that's good. You offer her, come back to the clinic, we will discuss what you want. Because that is not the place to discuss again what she wants.
But rescheduling must be with their choice.
With her choice. If the problem is that there is some problem in her house and she, for example, there's no one to look after her after the operation in her house, she's living on her own, then you should say that, okay, we'll reschedule that for you and let us know which date you want and we'll try and do it. But trust me, it's not very easy in UK to reschedule things. If you are off the list, then you'll be waiting for another 5-6 months to come back to the list.
So it may be sometimes if there is an indication for the surgery and there is a temporary abundance, we can reschedule not to lose along the time.
No. You cannot. That you are blocking the slot. You're blocking. It's the waiting list problem is so much so in UK is that they are losing a lot of money on that. And that they are trying to cut the list. So they say if you're not sure or your matter is resolved or whatever, then you should not reschedule it. You should not reschedule it. You can only reschedule it if a patient comes to you.
And you want to see her after the period.
Yes. If she has a period and you are going to
reschedule after the period.
After the period, or if she has a high blood pressure.
No, we just said that she is disputing the doctor. She is coming and she is not sure.
Not sure, then you cannot reschedule. No, you need to bring her back to the clinic to discuss the treatment with her.
If any social problem,
yeah, if social problem, like she doesn't have anybody to look after her for herself, she's an old lady living on her own, then you try and help her and reschedule on another date. But normally we say to the patient that please let us know beforehand, not on the day of the procedure, because you are losing the slot. This could have been given to another patient who has been waiting on the waiting list for the last 6 months. It's very, very rare in UK for a person to come for the surgery on the day and then say I don't want it because they've been waiting for that procedure for the 8 months or 4 months or 6 months. So they, in no circumstances they want to cancel it.
No, we are not waiting here. We just we can do the surgery sometimes at the same day. Because some doctors try to pick the patient before another doctor.
I think you are really ahead of the NHS in that respect. That you can reschedule the patient's procedure.
Another thing for especially for malignancy, or
yes.
a 6 weeks cycle to do the surgery from the time of suspicion.
That's right. Yes. A malignancy is different. Okay?
We have 2 weeks cycle and 6 weeks cycle.
That's right. Yeah, same in UK. 2 weeks wait. Are you talking about me? Oh, okay. I was impressed. No, I was impressed that it's so good in Egypt. You're talking about UK.
What is 2 weeks?
Okay, 2 weeks is if you are suspecting a malignancy. Okay, so the patient first comes to the primary care. Nobody comes straight to the hospital.
Like post-menopausal bleeding.
Okay, so they go to the GP. Now, GP has a duty that patient should be referred within 2 weeks to the hospital, which means that she should have a clinic appointment within 2 weeks. She should have some investigation done within that 2 weeks. She should be seen by a specialist and investigation should be done. And within 6 weeks, some sort of treatment, whatever is needed according to her, should have been started. So malignancy is very different. But otherwise, patients are on the waiting list forever. It's such a big issue. So if you are blocking the bed, if you are putting the patients on the list that are not sure about and they are more likely to cancel, or, then you are actually, your chief executive will really shout on you if he comes to know that that's what you are doing, because that's such a big issue. Okay, look at the questions. We were talking about the mental capacity X. So which of the list below are critical factors required to ensure that a consenting procedure is appropriate and valid? So again, we are talking about the validity of the consent, okay? So the first is the shared decision making. What is shared means between the doctor and the patient, yes? So remember we talked about when the consent is valid. Do you think this is critical? Okay. So what are the critical steps? That it has to be voluntary? Yes, there should be no pressure to the patient. Yes, person has to be competent and sufficient information. So these are the three important things. So when we talk about the competency, again, I must say that age is you should not confuse yourself about the age. A 13-year-old or a 14-year-old can give you the consent as long as you have assessed her that she has a capacity to understand the procedure, to understand the treatment. You should not judge her, right, in another way, that she is young, too young. Shared decision making is very important when you come to the conclusion. Okay, so this is the process towards choosing an option. This is not necessary to make the consent. Do you understand what I mean?
Shared decision meaning that the patient and the doctor have the same decision?
Not necessarily, but they share decision making. For example, a person has a problem with menorrhagia, okay, and she has a fibroid, and she is 45-year-old, and you think she's completed her family, and so you think that she should have hysterectomy, right? Because family is complete and there are multiple fibroids and not a fibroid in the cavity, but a fibroid outside. So you think that hysterectomy is a good option for her. But she said, no, I want to have a moving of her. Okay? So even though you think as a doctor that hysterectomy would give her a permanent solution, but she does not want to have a major surgery, full stop. So the end outcome is not what you both decided together. You wanted something different and she wanted something different. Sorry?
Shared decision making يعني معناها means يعني دكتور
No.
No, the decision of the patient should be shared with
the patient, with the doctor. Okay, let's give you another example to make you understand. For example, yes, a patient who is gravida 5. Okay, a patient who is gravida 5. She is 39 weeks. Okay. And she's got a severe SPD. Do you know about SPD? Symphysis pubis dysfunction. Okay, and she's requesting an induction from you. Induction of labor. Okay, she's gravida 5.
What's the consistent age?
39. 39 years. Okay. So, as a doctor, what would you say? And then there is another patient who is primary gravida. She's 39 weeks. She's also requesting an induction from you. With SPD. With SPD. As a doctor, how differently you treat both? Would you apply the same principle or decision for both of them? What factors would you consider for each patient? So let's talk about primary gravida. Would you, if she asked for induction at 39 weeks and she suffers from SPD, No. Okay. What about multi-gravida asking for the same question, severe SPD? Okay. What makes you to give different decision in both of them?
I have a big baby and a difficult delivery. It's not a great percentage.
Well, she can have a big baby, but the chances are, if you start an induction, she will labor very quickly and she'll deliver very quickly. Okay, and she's suffering from SPD, and she has labored normally before. So what you say to her is, okay, I will assess you, check her abdomen, do a vaginal examination, maybe do a good stretch and sweep. Okay, stretch and sweep. membranes, yeah. And you say to her, okay, come back in a few days, in 1 or 2 day time, and then we'll see. With regards to primary gavita, there's much more higher risk that she can end up having an unnecessary cesarean section if you do an induction and it fails. Okay, so you might say to her that, okay, you offer her analgesia, you offer her support for her SPD. Okay, you say to her, see your community midwife in a few days' time. She can have stretch and sweep at 40 weeks because that is the natural way to start labor, one of the natural way to start labor. You know about stretch and sweep, yeah? So your decision is different for both of them. Okay, so which means that you are not 100% agreeing to start an induction straight away, but you are doing something to help to start the induction naturally. So you have come to a decision that's called shared decision making. So you have not completely refused to the patient, but you have assisted her in some way for her to achieve what she wants to achieve. So that's what we call shared decision making. So you are not just saying no to what patient is saying. You're helping her. That's called shared decision making. Consent, no.
Patient can refuse.
Patient can refuse, absolutely. And patient can choose what treatment she wants to have. Okay? Okay, so this is the Mental Capacity Act. So carrying out an intervention on a person without her informed consent could technically be constructed as an assault to a patient. So Mental Capacity Act protects the right of the people who, due to an underlying disturbance of the mind, are unable to make decisions regarding proposed intervention, including treatment. It states a person lacks capacity in relation to the matter if at the material time he is unable to make a decision for himself in relation to the matter because of the impairment or disturbance in the functioning of the mind or brain. So this was the one I was talking, this is the act that actually protects the right of those patients who are unable to make a decision. So for example, patient with dementia, okay, for example, mental condition. So there is system in place. How do you take the consent for those patients? How do you give the treatment to those patients? So there are different regulatory bodies involved in it. You might have to obviously you have to involve their family. You have to involve their relatives. You have to sometime get the judgment from the court. You have to sometime involve the social services. You have to also involve the carer looking after the patient. So it's not just one person.
Another question is, if the patient is deaf, so we have another person, a third person, who
Interpreter.
or translate what you're saying.
But not from her family. It should be a professional interpreter.
Yeah.
Should he sign with this? You said the consent is signed by the doctor, the patient,
Yes.
and
Yes.
this
Yeah. She needs to countersign the consent form, that person present who's interpreting the information.
And she's the one to be asked if he got the message right. He knows what will be done to him.
That's why you need a professional interpreter, whether it's for the language, whether it's for the deaf person, because they are professional people and they will be questioned if any issue arises later on. Plus, you being a doctor, your patient is in front of you, yes, you can also judge what the understanding of that person is. Even if she is not able to speak or not able to listen, you can still, and that's why making the diagram is so important, showing the diagram is important. You can ask the person what's her understanding is by making a diagram and show you what's her understanding is. So there are different ways you can assess the capacity. Okay. In relation to so in this definition, there is something called in relation to the matter. A person lacks capacity in relation to the matter. What does in relation to the matter means? Which means that some people might have the capacity to understand simple things, but they may not be able to understand the more complicated things. For example, mentally disabled people, some people have different degree of handicap. They are mentally handicapped. They are able to understand the simple matter. They are able to do simple stuff, but as soon as you provide them complicated stuff, they're not able to understand. And in that scenario, you apply the Mental Capacity Act, and you need other personnel to help you to come to the decision. That is what it means in relation to the matter. If at the material time, what does it mean? If at the material time is unable to make a decision. Now, some people, mental capacity, they fluctuate with the time. For example, dementia people. In some parts of the day, they have very good memory, and in some parts of the day, they don't actually recognize anybody. So it's what we call the fluctuating memory. Similarly, if the person has taken a decision before he become unconscious, like Jehovah's Witness, right? And now he's unconscious, you still need to respect the decision that he has taken before he become unconscious. Yes? If the person has taken a decision, okay, I'll give you an example. If a person has taken a decision that she does not want a cesarean section at all, okay, and she comes in labor, and she's on the CTG, and the baby she had a massive bradycardia. What will you do?
She is competent.
She's still competent.
I will ensure of her competency by applying capacity principles. And if she is competent, after doing the regular procedures of documentation and informing consultant and whatever, I should obey her decision.
Choice.
I can repeat the question in our here. Telling her about the circumstance we are in, and I'm sure from here that you are still want to very
yes.
If she tell yes, I will do what she.
Yes. So remember, the unborn child doesn't have the rights. Okay. So mother choice is more important. Mother condition is very important. The scenario is very different if the mother starts bleeding. Okay, so there is one scenario we said that the baby had a bradycardia, and I had the similar case, I remember, and we could see the midwife was so stressed in the room because she could hear and she could see the baby heartbeat dipping and dipping and dipping and dipping, and this patient just did not agree to have a cesarean section. Okay, and we have respected that decision because the unborn child does not have any right. I put that scenario another way. If this patient starts bleeding heavily, okay, what would you do? Benefit for the patient, okay? Life-saving. So here comes the question of that you did some procedure in order to save the life of the patient. But would you do the same with Jehovah's Witness? No. It's a different scenario, right? So, because even though if you save her life, she'll penalize you in the court. She'd rather want to die than having the blood from another person. Oh, that's okay. Yes, that's okay. I'm talking about.
Every procedure except blood transfusion.
Yes. Alternative to blood if she has agreed to it, either plasma or I don't know, platelets or whatever. But you cannot give her blood. Okay, you cannot give her blood. Salvage. The blood salvage technique.
Are they accepting the blood?
That's also in the advanced directive. That's one of the options. So what is blood salvage technique? Yeah. So what happened is that during the surgery, all the blood that the patient is losing, it goes into a machine, Okay, it's like a sucker. You know, when you put the suction to suck the blood when you're doing the surgery, that simple suction is attached to the machine with a pipe. So whatever blood you are sucking, and we do it very efficiently in Jehovah's Witness. Okay, so that blood is actually going into the machine and then it filters and the same blood is coming back. Now, there are some Jehovah's Witnesses who actually do not agree with blood salvage technique, and the reason is that they believe that even if they don't want an external blood, but if the blood left their body, it should not come back to them. And some Jehovah's Witnesses, they accept the salvage techniques. Well, that's must. In scenarios where you are operating onto the placenta previa, placenta accreta, in the difficult surgeries, salvage machine, it has to be present, and it is available. It is available in the UK.
Witness accept the plasma and affect the arteries only blood reduce.
There are different types of Jehovah's Witnesses. Some just do not accept anything. Okay, some accept few things. And there is a whole option of the list in the Jehovah's Witness form. It's called Advanced Directive. So you must have that form in her notes. Okay, we are dealing with the pregnant ladies, we are dealing with the ladies in gynae. So whatever the case is, they should have those signed directive, advanced directive. They actually carry that with themselves. Even if they are not coming to the hospital, they carry that advanced directive with them in the wallet or whatever. If they are coming across an accident or something happened, people know that she's a child. Sometimes they have to breastfeed for the other people to know. Okay. So this was consent. Any question about the consent or mental capacity, how we assess the mental capacity of the patient? So you make sure that she understands the procedures, you make sure she retained the information, you make sure that she's able to tell you back what she has understood. She must be aware of all the alternatives. So that's how you assess the capacity or the competence of a person, whether she's able to give the consent or not. Right? Okay, we come to confidentiality, and confidentiality is another important part of medical ethics. Why confidentiality is important? It is like a trust between a doctor and a patient. The confidentiality principle of the rule does not apply to an adult patient, it applies to a young child as well. Okay, a 13-year-old coming to you asking for contraception, you are obliged, your duty is to keep this information confidential. You're not telling her parents without her consent. Okay, and you make sure that you keep that information secret. Okay.
I would like to discuss some areas in my presentation related to the taking
consent.
Yes, can you
please
answer? Like in advisory mental acts, like some regulatory actions that may be done for who are not competent to take decisions. I'm sorry to interrupt you.
No, it's okay. I mean, it's the best way to...
The computer is actually from 3 days. Is it or is it the presentation?
Yeah, this is the presentation. This is the concept. This was the one. Yeah, this was.
Yes, I think.
Yeah, this is the cousin.
This is the one. Court appoints duties and individual mental capacity. Can we discuss?
You can discuss this. I didn't read it, so.
When to take the decision to the court?
Okay. So this is the one.
Yes, it's okay.
So Dr. Ahmed, just want to discuss this in relation to the previous the consent we were discussing about the Mental Capacity Act. So when I said dealing with the patients who do not have the capacity because of their mental illness to give the consent for the treatment, so you can actually refer the case to the court, and then court needs to take a decision. You can give your judgment as in the best interest of the patient. That's what you think should be done for the patient, but you cannot take the decision on patient's behalf. You can tell the court that's what you think, this is the scenario, and then court needs to take the decision. So in this slide it says if a person lacks capacity to make the decision relating to their personal welfare, then the court of protection can make an order making the decision on their behalf. Okay. Alternatively, the court of protection can appoint a deputy to make a decision on behalf of the person who lacks the capacity. So as a professional person, as a clinician, you will give your advice or you will give your judgment. And then you leave it up to the court or the deputy that was appointed by the court to take the decision. Well, the thing is, if the patients like these, when they come to the hospital, usually the work is done before they come to the hospital because they have been looked after by the carers, they have been looked after by the social services. So there is always a chance that they might end up in the hospital in different scenarios. And therefore the things are usually in place for them, that if this happened, then what should we do? If this happens, then what should we do? If she needs resuscitation, then what should be done? But in an emergency scenario, things can be done quite quickly.
We can have court reply within, I think, less than 1 hour for some.
Yes, that's what I'm saying. If an emergency situation, it's usually very quick because there is a specific department in each hospital that deals with this kind of a problem. And they have an access to the court or to the judges or to whatever the relevant authority very quickly.
So we can take a decision like a woman is known to have a psychiatric illness that affecting her capacity, like to have a schizophrenia, for example, and she is pregnant now. Can we plan in case of having fetal distress intrapartum, what will happen to her during the antenatal care?
Well, that's absolutely fine because in UK, it's very rare for someone to turn up with schizophrenia at 39 weeks in labor.
Yes, there is a known psychiatrist.
Yes, they are usually seen, not just schizophrenia patients, all the pregnant ladies are seen by the community midwives, they are seen by the GPs, the action plan in place for them, social services have been involved, the consultant knows about those patients. In their health record, there is a whole list of things are usually mentioned and the plan is put in place before they come into labor. So it's very rare that someone just turns up with this problem and then you are sitting on the labor ward and don't know what to do.
So if we discuss with her the situation and if we have a fetal distress, what will we do? And we find her response is no, deliver me vaginally, whatever the situation. Can we do it prospectively before having labor with the court? Or
I mean, if she has made a decision,
a statement, yes,
as a statement, when you think she was competent, she has a capacity, you need to respect that whatever the situation is when she comes in labor. But if you think that she doesn't have a mental capacity, she's not competent while she was taking that particular decision, you need to consult the relevant people to take the decision on her behalf before she comes into labor.
So we can assess the capacity with the help of psychiatrists, for example?
Yes, there is a mental health unit. There is a community psychiatric team. and then there is a specialist
perinatal mental
team.
yes, perinatal mental health team.
Mental health team, yeah. They work in the community. So when you're working in the secondary care in the hospital, you're not, you're lucky in a way that you're not dealing with all these issues, arranging all these issues, because they have been arranged in the community. It's a very well organized system. Even if they are at home, there is someone to check on them, whether it's the GP or it's the community midwife or it's from the mental health team. Okay, so it's very, very rare for a person to turn up on labor ward with this problem and has no plan.
But if it happens, we find that she is in labor now, but we have a doubt about her capacity because of abnormal behavior or her response is not appropriate or whatever. Can we take or we refer the decision to the court?
Absolutely, as long as it's not an emergency situation. When you are saving the life of the patient.
Yes, but for the baby, it is for the baby because it will be for another person, not her, not he, not her.
You mean the baby has fetal distress?
Yes,
and
fetal
you want
distress, and she doesn't want to have syringe, and it looks from the situation that she lacks the capacity
to understand it.
Yes.
Okay. I think in that scenario, again, the unborn child does not have the right. Okay.
She doesn't have the capacity.
Please wait till we finish. Yeah, yes.
No, it's okay. It's okay. So always there when such. You mean when this person turn up, there is nobody with her.
Even her husband is with her, and her husband is pushing us to do a cesarean section.
You cannot do a cesarean section.
But we need to, as long as she doesn't, or it seems to us that she doesn't have the capacity. We can have a court action.
You can have a court action, and that is a situation where you can have the court action and within
30 minutes.
Not necessarily 30 minutes, but again, you have to make a balance between what are the benefits and what are the risks. If you are doing a cesarean section, putting patient at risk, then I don't think so you should do a cesarean section.
Yes, but if there is no risk, it will be a straightforward cesarean section.
How do you know it's a straightforward cesarean section?
No.
Emergency cesarean section can never be straightforward. Well, exactly.
No, this is another.
But this is a life-saving section.
This will not take a court action. You will do what is the best for him.
Best interest of the patient, and that is a life-saving situation.
But I think we need to take court action if we are going to save the life of the baby, and she lacks
the capacity to understand it. That is the thing.
I think that if we did what she wants, that we delivered the life, and this baby ended to be seeking or needed ventilation or whatever intervention was made of it, and then comes her husband or she is more aware after labor that why didn't you do the best for me and you take the baby? Am I going to court for it?
Well, when you're saying that she doesn't have a mental capacity and later on she had the mental capacity, what kind of condition she had? Are you talking about that she's in pain or she's unconscious or why? If she doesn't have a mental capacity, she doesn't have a mental capacity.
She had a diet. She didn't imagine that
so
this is...
You will judge her capacity. From the previous questions, you will judge the capacity. If she has the capacity, you need to obey her orders as long as, even if it's non-rational, especially regarding the fees. If there is a suspicious or she lacks the capacity, you need to, after proper judgment about her capacity, I think you need to take a court action rapidly, and most of court will support you to deliver or to take support your decision. Okay, am I right?
Her and the baby.
Sorry?
For saving her, you do what's the best for
What's
her.
the best for the
If
patient?
there is a severe antepartum hemorrhage and she's in panic attack and tells you she lost her capacity. No, don't do anything. I will die. I hear sounds that I will die. Whatever.
Yeah.
No, do what is the best for her.
Yes.
But for the baby, you need to take another opinion from the court. This is what I'm understanding.
If the patient lacks the capacity to make a decision for cesarean section, right, and you only want to do it for the baby's sake, then you're not doing good for the patient, because anything can go wrong with the cesarean section and she can die of the hemorrhage. So mother comes first. Okay, mother comes first. And also, the court will not penalize you as long as you have tried to put things in place to make sure that the person who is lacking the capacity, you made every single effort. For example, you have involved the relevant department from the hospital. You have involved your senior consultant. You have involved the senior midwife to come. You involved the social services. You involved the family. And after that, you have done something which you shouldn't do, then the court will not penalize you, okay? Because you have tried to put things in place that is required in that situation. And they didn't work. So you end up doing one option or the other option. The court will not penalize you. But if you have not tried to put things in place and you have just done what you wanted to do because you think that's best for the patient, then the court will question you. Did you actually contact that person? Did you actually try the court? Did you contacted us? And if there was a delay and you did something, then you're okay because at least you tried. So therefore the documentation is very, very important.
Also independent mental capacity are good.
Yeah. Yes, you can.
I was thinking that the court is the industry going to us because I think before there is a decision maker for their relatives.
No, we will not obey her relatives. We can. It can be what we know. We need to know from her relatives. What will she do if she has the capacity? It's like this.
And also there is a, sorry, I'm just cutting you, there is a legal department in each hospital. Okay, there is a legal department. You need to involve them. You cannot just go pick up the phone and speak to the judge.
They will contact
They are the professional people. They are the trained people. They know how to contact the court. They know how urgent it is. They know how to get back to you.
Okay.
And they know what to do if there is a delay.
And the court also can assign a deputy to take the decision. If there is a conflict or they feel that your decision is not the right one for this patient, they can assign some bodies from the hospital, another consultant or another body to take the decision. Another thing called independent mental capacity advocate. I think and you can tell me if I'm right or wrong, regarding some people who has a serious medical problem and they are not having the capacity, and they need to take many decisions in their course of treatment. There is like a assignment from the NHS to separate from the treating doctor to go through the decisions for the treatment.
So I think you're right. So in this case scenario, there is always an expert panel, okay, which is they are independent panel and they are not necessarily treating the patient. They'll obviously take an advice from the consultant who is looking after the patient. But they will also take into consideration of patient's right, even though she doesn't have a mental capacity. They'll also take different other things into consideration, i.e. her family's religious background, values or whatever. And the evidences, what are the evidences available on that issue? And then they can make a decision on that. So there's always a panel that involves different professional experts. So not necessarily the consultant looking after the patient. Okay?
That's it.
You sure?
We have some situations where one mentally retarded parent comes to us and the parents ask for supervision. For him, could they take the pregnant? So that's situation.
Okay, and she doesn't have a mental capacity to make this. Okay. You need to assess. Again, this is where the mental act thing will come. So you need to involve the relevant people. Okay, how likely is the possibility that this person can be sexually active? She doesn't have a mental capacity, so how likely is that she?
They are afraid to be raped.
Okay, well, this is and this is a very serious. They need to assess why they are thinking. So, what is she is at risk at?
And you may involve the
social services
for sure, because
So, if they decide, if the expert panel thinks that her risk of getting raped is more than the risk of her having the tubal ligation. So, what are the risks of tubal ligation? The surgery and the bleeding and the infection. So, if the risk of her getting raped is a lot more than the risk that she will get by a simple surgery, then they will say, okay, she can have tubal ligation. But if they think that the chances of her getting raped is actually not that much as compared to putting her at the risk of having the surgery, then they may say, well, actually, she can have the merino coil.
But we need to protect her from rape.
Well, that is
this
a
is
different.
the most important issue in the beginning.
This is the social services job. And they will, the Child Protection Act will come into that, and they will put the system in place.
There is a Protection Act for mentally abnormal.
Yes.
What's
there is
the
one we were discussing is the Mental Health Act. No, this is your.
And
sorry.
I know it's difficult I think even for who are expert to deal, and he needs to be very anxious and very critical when he...
And you need to judge case by case. You cannot apply the same principle in each case, okay? So when you were talking about that she getting raped, so the solution for her not getting raped is not for her to have a tubal ligation. Yes, if you are doing it because you want to protect her from rape, then tubal ligation is not the solution. What is the solution is that she needs to be protected. She needs to be in protected environment. Social services need to be involved. If they are worried for her to get pregnant because she is sexually active.
But at the same time, we need to give her the right to have sexual.
Yes, that's what I'm saying. If the question is about that she is sexually active, and it's not the question about rape, she has a right to be sexually active. She has a right to have a boyfriend or husband or whatever. And you are worried that she is not mentally competent to look after the child, and you want her, the parents want her to have the contraception. Then you need to assess the risk. Okay, you need to assess her mental capacity, whether she's able to look after the child or not. And then you need to decide what is the best form of contraception for her. I
think we need to have a court action.
Oh, yes.
We need to support our decision.
It's not something that you need to take decision on your own. The court needs to be consulted on that. Sorry?
No.
Yeah. No. It's not just what the parents have come to you. They have come with a problem to you. This is a dilemma. This is a conflict. And you need to consult the court to come to a decision. Okay?
Is there a consent from a competent person? do you have an autonomy for anything in Egypt? Does anyone respect your autonomy for political or for anything? And we are in a different environment. No restriction for autonomy at all.
Already. A girl in a 13 years old, 16, 21 كمان. She comes to the clinic with her mom already. How should I assess her and tell her you could take contraception كذا or not, or you could deal with your boyfriend with كذا or not, while her mother is already there?
No, but you need to ask her mother that she needs to leave the room.
That means she will wait outside with a knife and kill me and her in the same session.
We are now in UK, not in Egypt.
So when you're attempting an exam, imagine yourself, you're sitting in a UK, right? For some time,
when
you're out of Egypt.
Come to school, you are in UK. You have your autonomy. You can refuse the lecture. You can go at any time. So this autonomy is not available in.
So you think yourself as a more sophisticated environment when you are giving the exams, right? Okay, we were talking about the mental. Coming to the topic again, I think we are drifting to a side. So, Mental Capacity Act is the act that protects the right of the people if they have underlying disturbance of the mind or unable to make a decision. This is different from the Mental Health Act. Okay, the one we were talking about. The Mental Health Act, I think it deals with the patients who have the underlying mental problems. Mental Capacity Act not only deals with the underlying condition, but it can be on any underlying condition. For example, the patient has a severe hemorrhage, okay, and is unconscious, not able to make the decision. So it's not dealing with the mental health problems. That's the Mental Health Act. Yes. Okay. Okay, confidentiality. I think we should move forward because there are other things we need to discuss. So we have discussed the consent, important part of the ethics, and the confidentiality is another important part of the ethics. And confidentiality is to actually, it means building a trust between the patient and a doctor. Okay, whether it's a young person, whether it's a 13-year-old child, or whether it's an adult. You, as a GMC doctor, as a doctor, this is your moral duty to protect the data, to protect the information that the patient has given to you, or you know about anything for the patient. Okay, so the GMC in 2006 has said that patients have a right to expect that information about them will be held in confidence by their doctors, protection against improper or unintentional disclosure, and sharing of personal information. Can you disclose the information of the patient? Under some conditions. So you should disclose the patient information with patient consent, because if the patient say to you, I'm okay with you to discuss my problem with my mother, then you are okay to discuss, okay? But there are some situations where you can disclose the information without the patient consent, and that is very important to know, okay? Okay, so what is the act that deals with the confidentiality, first of all? So formal access to health record of the living patient is regulated by Data Protection Act 1998, and the access of health record about the deceased patients who have died is Health Record Act 1990.
I'm sorry, but there is a question we have solved it. It was about dead patients.
Okay.
And it is about Data Protection Act, and it was false. I think the data even of the dead patient is protected, but not by this act.
What
there is
is
another
that?
act. I don't know. But because in single best answer question, it was,
what were the other acts?
I cannot remember the question, but the word. Can you remember it? Yes.
He was asking about, I think, the Data Protection Act is only for the living patient or living and dead patient, and we choose
the dead was wrong.
And dead and living patient.
No, it was living only. It was living.
So what was the
right
right
statement? The statement of Data Protection Act is only for living patients. This is the statement, and it's law. And we need, when we are applying, we need to go through the law. Okay, I can see.
Okay. As far as I know,
how long is the data must be kept for that person, for any person? That record must be kept for how long?
I think it varies what kind of information is, because if you talk about the CTG, then it was for 25 years. Once the CTG information should be kept for 25 years.
And actually now the data, I think in most hospitals becomes electronic, and it can last for longer.
As long as you
want. The patient can come back and ask him for the records.
Yes.
Many years. And she pays something for this.
No. Okay. Who can access the record? Now the patients, including patient age under 16, are entitled to see or be provided with a copy of their records if they have the competence to understand the nature of the request. Again, you need to check. Okay. Any competent person may also authorize another person to seek access. For example, if I want, I can, if I ring my hospital and I have some blood tests taken, right, and I need a hard copy of those results. For example, I do not have access to the email and they cannot send it to me. And my husband just happened to be in UK for some meeting. They will not give the hard copies to my husband unless I phone them or I give them the application form and say that my husband can have access to my records, and I authorize my husband to pick up the reports.
And this access is limited to special things, not a free access to all of the files.
No. So we'll come to that. If you need to disclose the information, what information you should disclose and how you should disclose the information. So it's not like if I said my husband can pick up the blood results, it does not mean that the hospital should give all the previous record to my husband. If I only authorize the blood test results, then it has to be just the blood test results. I can phone them. I can phone them, but they need to do some security check even on the phone. Yeah. What is my date of birth? What is my first line of address? So it's not that anyone.
Everything is not a problem.
Yeah. Okay. Okay. So who can access the record? Anyone can access the record as long as they're a patient, obviously. They're entitled to see child under 16 if they authorize somebody, or any other patient who authorized any other person to see, so they can access. With their consent, remember, with their consent. Okay?
Anybody in the world can access to it.
That's sharing the information. Okay, and that's not something that you should be asking patient. If you're working in a hospital, you can have access to the patient record. And this is something sharing within the professional bodies. And that's okay.
In front of each other.
If they have authorized each other, or if they are sitting together, then obviously you cannot hide. Okay. Can confidentiality be broken without consent? So once we said that with consent, they can have access to the copy of the information. So you should not give them original notes. Okay, there has to be a copy of the things. But what are the circumstances where no consent is needed? Yes, confidentiality without consent may only be broken in the most exceptional situations. The health, safety, or welfare of the patients or the other would otherwise be at great risk. Okay, and so these are some examples that when you should disclose the information without the consent of the patient. Okay, so public health, for example, Control of Disease Act 1984. This was from your presentation in different slide, and it's still valid. So, for example, notification for the TB, notification for the AIDS, and other diseases, because the other people
AIDS is not notifiable, but we need to register here in, I think, for special registration program, especially during pregnancy.
Oh yes, yes. National Health Services Venereal Disease Regulation 1974. Sexually transmitted infections. Again, it needs to be notified and registered. Needs to be registered. So all those sexual health clinics, patients are coming and they have sexually transmitted disease. It needs to be registered. Needs to be notified.
Yes.
Yes.
Even benefits.
No. It's a notification for some bodies in public health or NHS, not for anyone.
Not for public.
Yes. And also for Zika virus now, it should be registered.
Yes. Zika virus is something.
Yes, I think it should be added to
the public health thing?
Yes, maybe, I don't know.
Yeah. Abortion Act 1967, as we have discussed before, that you need to notify to the Chief Medical Officer. You remember the forms we were discussing? So the last form was to send it to the Chief Medical Officer within 14 days of abortion or termination. All the terminations. So it's like a national data.
Yes. Female genital mutilation, any woman
yes,
with female genital should be registered in a special registry.
Right. So these are the circumstances that we discussed when you can disclose the information without patient consent. Also, if there is a request has come from the court, okay, for example, child abuse case, for example, domestic violence case, and the court has requested some information, so you can disclose this without patient information.
If we find a woman at danger because of domestic violence, we can reach the confidentiality and
to the relevant authorities. Obviously not to the relevant authority. What are the relevant authorities? To the social services, to the GP, because these are the people in the community.
Can protect her.
That can protect. You are not the one going from the hospital to protect her. If you don't notify to them, you will be penalized in the court, because these are the people who will make sure that she's protected. You need to inform, they need to inform the police if they think it is necessary. You don't need to inform the police. It's the duty of the social services to judge whether the police need to be involved or not. And in most cases, the police need to be involved. Okay?
But not by you.
Not by you.
Because there was a question about some woman had her husband in the prison.
No, it was about a girl, a young girl. She is raped by her stepfather, and he has just come out from the prison, and
we noticed abuses in her body.
Yes.
Something either we.
But no. This is the answer was to police for this.
Okay, no, I tell you what.
Because he is a criminal. This is not will go into the.
This is reporting a crime. Okay,
yes.
So this slide is about
this is reporting a crime.
Crime. You are reporting a crime.
Even if you are not a doctor, you need to report this.
Because this is a crime you are suspecting. Okay. On another case, if the police come to you to ask for information, then you need to tell the police. Okay. So there's no legal obligation on a health professional or any other vendor to report a crime except when the information disclosed might be assisting in preventing the terrorism or if it is a crime. This terrorism is something new that has come up, and they're taking it very seriously now. Okay. So, however, in some circumstances, it is possible that a health professional could be liable in law if serious harm arose from his or failure to disclose information to an appropriate authority. And this is something serious that we will discuss in the case. So, you need to involve. But in such situations, you're never alone. You're never dealing with these cases alone. There's always a team with you, and they will guide you. In UK, you're never alone dealing with difficult situations.
Immediately. Even in legal parts.
Absolutely. There is a multidisciplinary team. You're working as a part of multidisciplinary team. They will guide you what to do.
Being important to child protection from being important to a social worker or to the police. In the case of child used or an older age girl having sexual abuse?
I think the 13, we said that the child is allowed to have a
sex. And the child is
after 13.
Still.
But then you need to see who is she having sex with.
Every case is different.
Different, okay? If you think that her sexual relationship is, if her sexual relationship is with, I don't know, 16-year-old or 15-year-old
or with one who has authority like a teacher in the hospital.
Yes, that is different.
Even if she is, even if it's above 16, if it's 16 or, if it's 16 or above, from 16 to 18, and who is practicing sex is a teacher. It's not allowed.
That's not something.
Who I will social group consider police what?
Child Protection Authority, as long as she is below 18.
Child Protection Team or Child Protection Unit is always there. So you involve them, okay? You involve the social service. So as I said, it's not just one authority or one person.
Child is up to 18. Like in Egyptian law, it is now it's up to 18.
18?
Yes.
Okay. So reporting a crime, when the court asks you to disclose some information to the public health, so these are the exceptional circumstances when you can disclose the information without patient's consent. Okay. So what is the Caldecott principle? Do you know about the Caldecott principle? So if you are asked to disclose the information, how you will disclose the information, as we were discussing before. So first of all, you need to justify the purpose of using confidential information. So what is the purpose? So for example, the court has asked you to give the information. For example, police has asked you to give the information. The social services has asked you because they're worried about some child. They're worried about the girl. So you need to justify why you're giving information. The second principle is don't use patient identifiable information unless it's absolutely necessary. Okay, so you can just do anonymous information, and you don't need to every time not necessarily write the name of the patient in the letter or whatever information you are given. You can write the hospital number or something like that. Principle number 3, use the minimum as required, as Dr. Ahmed said, so you don't need to give the whole 20-year record. Just make it to the minimum, just the information that is asked for you to give. Okay, access should be on strict need-to-know basis. Again, the same thing. What you have been asked, you need to give that information, not more than that, not less than that. And give your information in facts. Do not give opinions. Okay, so for example, a rape case has come to you and you need to give a report. So do not write, I think this can be because of that, and I think this, no. What is your, you did a vaginal examination, what were your findings? So vulva, vagina was how, and cervix was looking how, and the uterus was anteverted, or whatever you find, sorts or whatever you find. So give facts, not that I think this could be here, not assumptions, not suggestions. Everyone must understand his or her responsibility. So it's not just the medical doctor when you are giving information. It's also the nurse who has seen the patient, and also the midwife. So the same principle applies to everybody. Okay, and understand and comply with law. Obviously, you should know what is the law when you are breaching the confidentiality. You should be aware of that.
I think it's also applied when we are running an audit.
Oh yes, Caldecott principles is about the confidentiality. So if you are running an audit and you are putting your data on a piece of paper, then you should not put, you should justify why you're doing it, because this is for audit. You should not put the patient name or even the hospital number, because people can trace it. So maybe what you can write is Smith Jones, so SJ, something like that, just the initials. So something that's not identifiable. So, and use the minimum that is required. So just take the information that you require for the audit to put on the form. You should not take all the information. So the same principle apply to the confidentiality of the data. Right? And similarly, when you're sharing the information with your colleagues, you cannot do it through a normal emails from Yahoo or from, I don't know, Gmail or WhatsApp or whatever, okay? You need to have the hospital email address. Patient information can only be transferred to your colleague through the hospital email address. If you are going to transfer, or if you are going to send it to a normal email, some data, then there should be a password. You know, you can apply a password onto the data, and then that password, you need to tell that password to that person so that only one person can open that data. For example, in an Excel sheet, you send an Excel sheet for an audit, and not everybody can open that Excel sheet. Before you open it, there should be a password. There is a system that you can arrange. Okay, but the best is to go through the hospital email address. Okay, there are some examples. Can you read that, and then we will discuss it? Who's going to read it?
Read.
Normally, the labor across 7 weeks of registration is making born to rest in labor, and the baby has entered distress with the BF 7.1. The baby is growth restricted and is now freshly conium in the life. The woman is only 6 months dilated, and the children
I'm
of
gonna
the
read.
baby liver
No,
vagina
thank you
is
so
much
much.
small. It is known that the delivery or cesarean section is needed, and you consultant agrees. The pregnant woman refused, despite all efforts and persuasion to allow me to do this. Her husband also agreed with her. What should you do now? It feels that she is incapable of making a rational decision because she has had so much sedation in the notes in her birth plan. Commented that on no account would she agree to have a cesarean section. You still make the decision that you will do a section. You can hear that it's your intention to carry out the operation without her consent because you have to make sure that the baby has the best chance of survival and the baby's best interests supersede her wishes. You ask the consultant to attend to make sure that both parties understand the options and confirm that they know the chances of for the baby may be limited because then allow her to labor and document this fully in the case notes. You should talk to the husband separately and try to persuade him to countermand her decision in the best interest of the baby.
I think this is very straight. Sorry, I'm eating chocolate and I'm
Even
choking.
if the husband doesn't agree with her, you need to pay her as long as she has
Because you think she's under sedation, and she might not have the capacity at that time, but in her notes it's written that at no point she wants to have a cesarean section, right? So when she has even if you think that at that time she doesn't have a capacity, she made her decision when she has the capacity. And you need to respect that decision. And it's something you are doing for the baby. You're not doing for her. So it's a different scenario. Okay? Which is, remember, mother comes first. Okay? Happy with this? Any question?
About the so much sedation.
Sorry?
Taking so much sedation.
So that's what I'm saying. That she had so much sedation. You think she hasn't got a capacity, but she has written in her notes before. Did you see? I think there's somewhere it's written.
She wrote in the notes before she doesn't want.
Yes, where it is written. I read somewhere that...
It's documented that on the account you agree to have a continue to read a.
In the notes in her birth plan, it is documented that on no account should she agree to have a cesarean section. So she has made her decision beforehand when she has the capacity. Okay, this is just the answer. I think it's the answer to that. Okay? If she makes an informed decision to refuse the treatment, even when his result in her death or whatever, the decision is not respected.
Even in her death? Even in her death?
Yes.
Even when this result in her death? She said,
Well, the thing is, if her death happened because, if we are talking about the Jehovah's Witness, okay, if she has taken a decision, that she does not want the blood transfusion, even if she dies, then you should respect that decision. Okay?
So, can I refer to another doctor?
You can, that's what you did. You consulted your consultant to come and talk to her.
No, sorry, I mean, in that case, I find patient that she kind of said that even if she went down, she refused an operation or taking blood. Have I don't deliver her?
You have taken the consent before she went into labor?
Yeah.
I mean, if that's what she has given the consent for, that she does not want to take a cesarean section, even if she dies, then you need to involve other people, because you really need to assess her capacity, why she's saying so. If it's not the case of Jehovah's Witness, what she's worried about of having a cesarean section. So you need to address that issue, that what are the things. Is she in, for example, a patient who, let's take it another way, another patient who wants to have a cesarean section, who does not want to have a normal delivery, and she's having her first baby. Okay, you try and convince her and say there's no medical indication. Then you try and address the issue, why does she want a cesarean section? And then she say, oh, I'm really afraid of pain and I just cannot bear the pain, and it's the pain I'm worried about. And then you can offer her an epidural. So in your hospital, the policy is that person should have an epidural when they are 3 or 4 centimeter dilated. But in her case, the outcome is going to be so serious that she wants to have a cesarean section. You will say to her, okay, when you come in labor, we'll give you an early epidural. We'll give you an epidural if you are 1 centimeter. Or we'll give you an epidural before we start the induction. We don't do it normally to every single person, right? But if this is the special circumstances, then you really need to weigh. Giving her an early epidural would risk her, or me doing a cesarean section would give her more risk, right? So you do something for the patient in between.
I think she is asking about another thing. Yes, about if I refuse to deliver here because she will buy from me. She needs blood.
If she needs?
If she needs blood, she will buy from
Yeah,
me.
Jehovah's Witness.
Yes.
Yes.
Can I not deliver
Just like the question I asked you, is it a sort of suicide? She's choosing to die.
You're talking about Jehovah's Witness? That's her choice.
And it's my decision also.
Then you okay.
To another doctor.
Absolutely fine. If you think that she is not, if you're not, that's what I'm saying. You know, this is her. This is her.
And she has very good memory.
Yeah.
And she's thinking right.
Absolutely.
And she has the right.
Yes, absolutely.
But I have the right not to deal with this patient.
Absolutely, you can.
I can't stay
but
there
you cannot
watching her die.
Yes, but you cannot do that in the emergency situation when you're standing there as a single doctor, right? Yes, you cannot say because I'm the only doctor at that, so I'm just going to give her blood. No. Okay. It's very rare in the UK hospital that you're working alone on your own. It's always the team. It's always the team. There's always another person.
If the patient insisted that she wants a cesarean section with no medical indication, and I don't want to do a cesarean section, can I refer it to another?
Absolutely. Okay. Oh yeah.
If the patient has a problem in cesarean surgery and she wants to have an access to their records. Okay?
If patient has a problem in the
during cesarean section or whatever, and she wants to have an access to her own records.
Yes.
The question was what we can do in order to get it now. One of the options is to show her the records and have the hard copy of it. It was a wrong choice, and they said because she has to write it in request, and they please to have her own records. This is right. Then she can have an access to her own records.
When? During the surgery?
After the surgery, she wants to do a complaint.
Okay. Fine. Yes. Yes.
She can have an access or no?
She can have an access. That's what we said. Who can have an access to the patient record?
The answer is wrong. The answer no. Immediately when she comes to you, there was
Look, you need to, I think this is absolutely right. It's not that someone will come to my clinic and say, I want to see the record. No, you have to make the formal request to have it because you need to give her the information that she wants to see. What you have in front of you is the whole record. Okay? So if somebody comes to you and say, I want to have access of my record, then you ask her, what information would you want to have? And she says, well, actually, I want to see how I looked after during the labor. Then you say, okay, I will give you the copy of that. So you go back and you make the copy of the notes, and it will not happen straight away, okay? You ask her to come back. There's no emergency. Then you make a copy of that particular part of the notes, and then you give her the copy. Then you give her the copy in the most confidential way, okay? You put it in an envelope, in a sealed envelope, and then you give her the copy. So it's not like someone come to the clinic and say, I want to see the record, and you just give her the record. No, it's not like that. So that option is okay. So it's not immediate. She has to make a formal request. Anyone has to make a formal request. You cannot show somebody the hard file or the hard copy.
A question for hospital the same circumstance, and they tell me that there is a department in the hospital dealing with good practice with the patient or something, and they can convince the patient not to make a medication or something. So he tell us it's first to get their record, or first transfer her to this department.
If you remember last time I mentioned about the PALS service, Patient Advisory Liaison Service. Okay, this is called PALS. Okay, so this service deals with the complaints. So what they do is, this is the service in each hospital. They contact the patient before they make the complaint to see if they can resolve the issue.
So she comes to ask about the records, and
you still need to give her the record. Whether she complains, whether she does not complain, whatever the situation is. If she wants to have the copy of the record, you can ask her, why do you want a copy? And she say, well, I just want to see it, I want to make a complaint. And then you give her the copy of the record and you refer her to this as well.
The choice will be
giving yes, because that's what she asked. Okay?
She said she wants to make a complaint.
Say she has every right to make a complaint, but you suggest, okay, you recommend that she should see, she's happy to see the personnel from PALS. So patient does not need to go to them. If patient agrees, then the person from this service will go to the patient. You contact them. Patient will not contact them.
Patient requests information and should offer them to PALS.
Well, depends why she wants a record. If she wants a record because she just wants to know, there's no reason why you want to. And then, because you know what, you need to justify the reason why you're giving the information. Okay? The first Caldecott principle was you need to justify the reason. So if someone wants to record, you can ask her. You have every single right to ask her why she wants a record. And then you write in the notes. Okay? Maybe after seeing the record, she decided not to complain. That's her choice. But if she wants the record, you need to give her the record. You cannot hold the record. By all means, you can ask her that if she wants help from this service. So you need to ask these person to contact the patient. If patient say yes, they cannot just turn up on patient bed. Okay, if patient say no, I don't want to see them, they are not allowed to go to patient. Yes. Last question, and then we'll move on.
If the patient is a criminal herself, and she is pregnant, and she's coming for antenatal, and she took any decision she wants for a restart, is she free to take her decision?
If she's competent, yes.
Even if she is a criminal?
Oh, she's a criminal. She's in jail?
Yes.
Like what kind of decision?
Like, I'd like to deliver normal, whatever.
Oh, yes. The criminal person has the same right. Has the same right. Even if
she said, don't give me blood.
That's absolutely, yeah. The being a criminal will not take your right to not to have that delivery.
And for this purpose too.
Yes.
If I know that she did something as a crime long ago, 2 years, 3 years ago, or something, should I keep it a secret, or should I say it?
Say to who? No, I mean, if, like to who? You're talking about, okay, for example, if you're saying that there is a pregnant lady and she has killed her child before, and she is again pregnant and she's going to have another child, then that baby, the social services need to be involved. They need to judge her condition, they need to judge her circumstances, and they need to decide that after the delivery whether the baby will stay with her or baby will be taken into their custody.
And in such case, I should inform.
You should? Inform.
I should say this, that she had a attempt before and she killed her child.
I think before you tell them, they already know what she has done. She's done a crime, okay? So I don't think so. You need to tell them. They will tell you before. If she has done a crime, okay, so you will have all the information with you. They will be more aware of all this before you tell them. Okay, let's move on to a second case. Can you please read, one of you can read the case?
14-year-old girl requests emergency contraception. She had unprotected intercourse with her 18-year-old boyfriend 2 days ago. She appears to understand the nature of emergency contraception, which is the most appropriate management. Personally, that she cannot have emergency contraception as it takes too long.
It takes too long.
It takes so long since intercourse took place. Advice here is that she is too young to be legally prescribed emergency contraception. Prescribed emergency hormonal contraception as advise her about future contraception. Prescribed emergency hormonal contraception only after informing her parents. Prescribed emergency hormonal contraception only after informing social services.
Yeah. I think that's very clear cut, and we have discussed it. Yes. So how old is she? 14-year-old. So again, we talked about the Fraser guidelines. We talked about the Gillick competence. So if she has an understanding of the emergency contraception, and you've judged her, even if she is under 16-year-old, and you have applied the Fraser guideline, which is that you know that she can retain the information, you know that she understands it and everything, then you prescribe the contraception. Okay? Case number 3.
Lawyer, and within 4 weeks into her pregnancy, she has developed BET and her blood pressure is inadequate control on 2 antihypertensive. Her most recent scan shows a fairly IVR baby with estimated weight with guaranteed refinement. His most likely response the AFI of 4.2 centimeters. And based on her algorithm, she has capacity and declining throughout and delivery possible infection within the next 2 weeks. When she delivers, she believes everything will be fine and she would like to avoid surgery. What is the best option available so they can start from managing the administrative under mental health act and give you the advice message and go to another consultant to see if they can bring the woman to change her mind, respect the woman's wishes and ensure regular follow-up. Respect the woman's wishes and ensure her own care. Take up most of the people the vision to have the advice.
You said, who said B? Everyone said B?
She's a lawyer and she can't understand what
So who said E? Why did you say E?
I think because the woman's wife is at risk, she's not careful
The woman has the capacity. She's harming her baby.
She's harming herself. That's why she already she's not.
Nothing wrong is going to happen to her if she's declining the steroids.
Yes. So do you think by giving her steroid will control her blood pressure?
No.
Do you think...
Delivery will
yeah, delivery will... on the other hand, but you can control her blood pressure with the medicines.
she takes 2 minutes and she can't.
But there's always a third one.
but
You can always...
solution is to deliver with clear sections better than
Okay.
waiting.
Someone has to convince her. Yes, that's good. But
A أو C. B أو C. B أو C. B أو E.
can you give a patient any treatment without her consent? No.
So I am involving another concept.
Okay, you're involving another consultant convincer. So that could be an option. Okay, I agree with you that you can involve another colleague to do that. But what are you doing in the meantime?
Respecting your wishes.
Okay, but you're respecting her wishes and you are not leaving her. What you are doing? What you are doing?
Ensuring regular follow-up.
And what does follow-up means? Okay, so blood pressure. So which means that you are checking her blood pressure. When you keep a patient with PET, with the preeclampsia in the hospital, what are you doing with that patient? You are checking the blood pressure. You are checking the protein in the urine. You are checking for the symptoms. Okay.
Follow-up is checking for all.
Yes, checking for all this. And she's a lawyer. Okay, she's not somebody who is a heroin addict. Okay, she can take you to the court. If you do something, if you do, yes. You can't force not just her. You can't force anybody.
Not a lawyer.
Not just a lawyer. That's a different scenario. That's a different scenario. No, I think that's different. What we are saying, yes, the risk is that she can have fits, but once she have fits, the risk is that she can die. Okay, when you say somebody has a hemorrhage, okay, a person who's having a cesarean section can have a hemorrhage, but a patient who has a cesarean section for placenta accreta can have a hemorrhage that she can die of. There's a difference. Okay, so if person is not taking her antihypertensive, yes, she can have fit. But once she have fit, she can die because of the pills. So there are two different things. And that is the life-saving situation.
I know, but with living, it's maybe within minutes.
Well, that's
She will come for regular fill-up. It may happen.
No, ensure regular follow-up does not mean that you're going to discharge her. You know, there is a separate D where you respect her wishes and you discharge her. You're not discharging her. Okay, you're keeping her in the hospital. Regular follow-up means you are what you are doing. Yes.
And she had one thing.
Yes, you do the discussion again. You rediscuss the circumstances with her. Look, sorry. It's okay, I'll get it. You rediscuss the scenario with her, the circumstances, but this is different now. We are not doing it for the baby. Now we're doing it for you. Okay? If she has an uncontrolled blood pressure because she on 2 antihypertensives. So what happened when someone has an uncontrolled blood pressure in labor? You start the drips, you start hydrolysine, you start Maxalt, you start other things. So you have not achieved the maximum ways to control the blood pressure. She's only on 2 antihypertensives. Okay? Yeah, I mean, if it's really debatable. It's really debatable. If it's an IUDR baby, yeah, maybe the steroids might do some good for the baby, but it's personal choice. Okay, another case.
Mention the sentence, she think everything will be fine. Think everything will be fine. She doesn't understand. Something wrong, she doesn't know what will happen.
Okay, if
the same question without this part, I will choose regular Quran.
If you're saying that she thinks everything will be fine, same with Jehovah's Witness, okay? She doesn't care if she dies. So does it mean that she is mentally not right?
She thinks everything will be fine, but Jehovah's Witness knows she will die and just it.
Yes, but do you think that's acceptable for your mind? A person who can risk her life and not having blood transfusion? No, but that's the thing. That's the thing. You can say
this part she doesn't understand. Something missing. I have to convince her about something.
You are judging the capacity of a person. Okay, you have given her the information. Don't go into too much deeper that she doesn't understand or there is some problem or no. If they have written she understands and she thinks everything will be fine, then it means she understands. And the reason they have mentioned a lawyer, she's a professional person. Okay, they might have written a heroin addict person, and that is a different scenario. Okay, this case, please. 9 minutes. Okay, before this one, can we quickly discuss this case because then I need to leave and I'll ask Dr. Ahmed to continue with what is left. Okay.
In her second pregnancy, she was sure of her date and her scans at 12 and 20 weeks agreed with the expected date. At 36 weeks, she attended the antenatal clinic with her husband and mother-in-law, insisting that her dates were wrong and that she was in fact at 40 weeks of gestation.
You have done it?
I think yes, we.
Yes, she became very angry and aggressive when the contract of scans.
But there is no question. This is just ethical.
No, I think we have maybe some modifications for choices or.
Okay.
Okay.
Okay, you've read the scenario?
Yes.
Okay.
And there is 4 options.
Okay, no, this is not single best answer. What were the options? Do you remember what were the options?
Yeah. One of them is try to convince the patient to tell them the truth and something like this. The other thing you can tell the grandmother and the husband about the actual date. And there is
another option.
Only one option to change. Right, one that we try to tell the patient to tell the truth.
To tell the truth. Okay.
No, not even to tell the truth. We will not change anything. We will induce her when she is beyond 41
weeks. Okay.
You are not going to give advice. Regarding your work, you will not change your work. You are a professional doctor, but you will not advise or make.
I will not change the time.
Induction.
Exactly.
But the change, I can to tell the patient, we try to advise the patient to tell the question.
No,
Okay.
This is formulation, not.
Okay, let's read this one as we go along. Okay.
Even she spoke to the midwife when her husband and mother-in-law were out of the room. She admitted that she and her husband had started her
Spill.
and
Not spelled. Separated. Sorry, this is the wrong spelling.
And she had sexual intercourse with another man and conceived immediately. She and her husband then reunited, and he thought the baby was his. Her mother-in-law had completed the dates and was worried she was overdue. The patient asked the midwife to lie for her and arrange induction to save her marriage.
So the problem, the conflict, is mother-in-law. I think. It's always the mother-in-law. Okay. So I'm just joking. Okay. It's not mother-in-law. No. Why would I? No, why would I add this detail? This was the question in strategy. Okay. This is the question. Okay. No, I have not included this myself. Okay. Right. Okay, so the main issue in this case is the confidentiality, because what the patient is asking is that I want to have the induction because of this reason, because my mother-in-law is thinking that, and she's asking you not to share that information and just give her the induction. Right? So, come to the principles. We are talking about ethics. Autonomy, patient's right. What is patient right? Does the patient have a right to demand induction at 36 weeks for social reason to save her marriage? No, we don't think so. Okay? If we say that patient have the right to save her marriage, okay, forget about the induction. She's doing it to save her marriage. That's her right to save her marriage. But on the other hand, the doctor's right is not to do any harm. So there is a conflict. Your duty as a doctor, and then patient autonomy to save her marriage. Right? So
I will not lie. I will not save her marriage.
You will not lie to save her marriage. What about the patient autonomy to save her marriage?
She has the right to save her marriage.
She has the right to save her marriage.
How? That's what she's saying. If I have the induction, this can save my marriage. Well, you cannot just refer patients to another doctor. Okay, this is not the solution. To refer patient to another doctor. If you don't know the answer, I'll refer it to another doctor. Okay, there is no other doctor. You are the only doctor. I'm just questioning you, okay? I'm not judging what you're saying. I'm just trying to question you. That there is patient's right to save her marriage. Yes, your duty is not to give her addition. So how do you balance?
Unless I'm going to harm her or the baby,
I respect her.
Okay, but fetus has no right. So you're not, with the induction, if there is something happened to the fetus, unborn child has no right.
Induction has no
1 week extra.
Yes, the patient has a risk. What is the risk? Preterm is for the baby. What is the risk to the mother? Failed induction, cesarean section, hemorrhage, hysterectomy, infection. Yes. So fetus has no right, but the doctor's duty is to prevent the risk of prematurity and to the risk of the mother, and then weigh it with saving the marriage.
Should I involve with her in this guide? And what about
Sorry?
Should I involve with her in this life?
No, I'm not
I'm not saying you should. I know as a doctor what your duty is, but what should you do for the patient autonomy?
What she insisted after knowing everything.
Look, I'm just questioning you. I'm just trying you to think. Okay, this is the ethical issue.
How can you convince the mother-in-law?
How can
the mother-in-law or as a husband?
You will convince the mother-in-law, she'll kill you with the patient. Okay? You cannot convince mother-in-law because you are breaching the confidentiality. And the issue here is you cannot do that. Yes. There's no way you can breach this confidentiality. There's no way to you. You can. Absolutely not. Absolutely not.
What about
This is very wrong choice. This is very wrong choice.
the patient knows about the risk of her morbidity and the risk of the baby, and she insisted to have this, to have the induction.
I can refuse?
You can refuse.
Why? Because we tell
For such a patient, what should you do?
we tell before if the patient have the capacity.
Okay. What is the main principle that I discussed when we were discussing principles of ethics? Do not do harm before you do benefit. Okay. Yes, patient has a capacity to understand. You're not questioning her capacity. But then comes, are you doing good to her or are you doing bad to her? Are you giving her more benefit than good? More benefit than bad stuff, than harm? So the first principle is do not do harm. Okay? You're not questioning her capacity. There's no questioning her capacity. Okay?
And the right.
My understand. Yes, sorry.
Yes, what I mean, you will not obey to do intervention. You may obey her in not agreeing to do intervention. And if there is an indicated induction and she refuses to have induction, you can approve her decision. But she cannot urge you to do induction.
Yes.
This is intervention. No.
And also, when I was thinking this scenario, I was thinking, would it save her marriage? No. This marriage is already in trouble.
Beyond the question.
This is no, you really, you need you need to think logically. That even if at some point, at some part of your brain or your heart will say, oh, I should save her marriage, but you should think radically, logically, that by giving an induction would save this marriage, which is already in trouble. I don't think so. This is not, there is no guarantee that this will save her marriage. Okay? So if she's asking an induction because she wants to save her marriage, then that's just not acceptable.
Maybe just a few and nothing will happen.
Nothing will happen. The marriage has clear problems. Right? The marriage has problem, but if you do an early induction,
no, these are your comments. It's not from the strategy.
This is from the strategy.
This also the marriage has
absolutely. This is from strategy. So if you go on to strategy and you look at the ethics section, this scenario is an ethics section.
Yes, but with these comments.
With these comments, I'm not joking with you. You're not trusting me. I'm not made it myself. Okay, if you have an internet, I'll open it for you. No. I'll open because your question. This is not Arabic.
Discussion about the long-term consequences.
Long-term consequences mean long-term consequences to the baby, to the fetus for prematurity. I'm not talking about long-term consequences of the marriage. Okay? No. It says the baby could suffer from long-term consequences for the prematurity. Okay? Okay. So beneficence, no one benefits. Okay? Non-maleficence, do not do harm. Okay? To the mother and the baby. Probity means honesty, the one we were discussing. So the GMC said the doctor has to be honest, has to be truthful. You cannot lie on behalf of the patient, whatever the circumstances are. Okay? You should not lie. So it would be reasonable for the doctor to decline to discuss the pregnancy with the mother-in-law and the husband. Okay? But doctors have the right to decline to lie on behalf of the patient, but then you should also decline the induction. The reason she's asked, there's no medical indication. You're doing more harm than good. And what she's making basis for the induction is quite ridiculous, that will save her marriage.
Sorry.
So what was the outcome?
Then induction was refused and she labored, she continuously accepts.
Okay? And I really don't know what happens to her marriage after that, because I've not made that scenario myself. I don't know. Sorry? Just give me one moment. So trust me, I have taken from strategy, and I'll send the link. I've sent the link to you. I have not made it. Yes, Mohammed. Yes, I'll do 2 in 10 minutes. Okay, thank you. Okay. Okay.
A patient and her husband.
Yes.
They had, I'm talking about religious things. They have to get married within 3 months, and they had something wrong, and she got pregnant, so they made it earlier for the marriage, but it was postponed out of no need for 1 month. So for her mother-in-law, she's in the 32 weeks. And for us as doctors, she's 36 already. Should I be involved in this line or?
No, but you should do what's medically indicated. If she's due for induction, she's due for induction. Okay, you cannot stop the induction because her mother-in-law will know about the circumstances.
She was pregnant.
Because your main priority is patient, is not mother-in-law. Okay, you have to do everything in the best interest of the patient. Mother-in-law comes.
As long as these things are physical and local, you will not lie.
There is another scenario. The patient has a previous history.
Okay.
And she become pregnant, and the baby is breech.
Mm-hmm.
And for her
No, even if it's cephalic and she needs to deliver by cesarean section, you will deliver her. You will deliver her by cesarean section without telling the husband or anyone. No problem.
Yeah.
You will do what is the best for her.
What's the best interest of the patient? Patient's care is your first right. Yeah.
This is common actually to see. Okay, and you need to ensure that the medical file in Egypt especially not available to the
confidentiality.
Yes, because the indication of cesarean section can be written in Arabic in the file. You need to take care of the file till she will be discharged. Yes.
Okay. So these are the acts. Just go home and have a read of those acts. And what I would suggest is make a list of all the acts and just write 1 line in front of all the acts and put it in the folder that I suggested in the morning. So that when you do the revision, you have all these things on 1 piece of paper. Okay? So my resources are mainly, so these lectures that I'm giving is mainly from strategy, from the exams point of view. They have put these lectures on strategy, and I suggest, Dr. Ahmed, you go on to ethics and look at the strategy, and this scenario is there with mother-in-law and everything. So I didn't put it myself. Okay, so this is the summary. I think what's left is we discussed confidentiality, consent, ethical approaches, principles of ethics, some scenarios we discussed, Is there any Abortion Act? We discussed the legal things. Fraser Guidelines, Gilead Competence. Things are clear for you. I really suggest you go home and read about this and attempt a few more questions. And come back and tell me next time if you have a problem. Okay? You're welcome. Well, if you want to say something on the presentation, anything left from your presentation? Because I just looked at the time and you're welcome.
I will tell them facts about
Given me the memory stick. Can you text me just for my record so that I have it? And I have the memory stick completed. Did you give it to me? Yes. I might have it. Can I have the pen? You need it? Sure. Thank you. Okay. اقول لك على مين ولا ابعت لي اي حاجه مهمه يعني اي حاجه الجايدلاينز الجديده الاخرانيه